Welcome to this continuing education course on concussion management in adolescents and adults. Concussion, also known as mild traumatic brain injury, represents one of the most common neurological conditions encountered across clinical practice, affecting an estimated 1.6 to 3.8 million individuals annually in the United States alone. Over the past decade, the clinical understanding of concussion has undergone a profound transformation, shifting from a model of passive rest and symptom monitoring to one of early active rehabilitation, individualized assessment, and multidisciplinary management. The 6th International Conference on Concussion in Sport, held in Amsterdam in 2022, produced updated consensus recommendations that have reshaped clinical practice guidelines worldwide, and a growing body of randomized controlled trial evidence now supports targeted interventions that accelerate recovery and reduce the burden of persistent post-concussion symptoms. This course provides an advanced-level, evidence-based update on the assessment, management, and rehabilitation of concussion in adolescents and adults. It is designed for physical therapists, occupational therapists, nurses, and all other applicable allied health professionals who encounter concussion patients across the continuum of care, from acute sideline or emergency department evaluation through chronic management of persistent symptoms and structured return to sport, school, and work. Each module integrates the most current research evidence with practical clinical applications, reflecting the interdisciplinary nature of modern concussion care. The course begins with a comprehensive review of evidence-based assessment protocols, including the Sport Concussion Assessment Tool, 6th edition, known as the SCAT6, and the Sport Concussion Office Assessment Tool, 6th edition, known as the SCOAT6, with attention to discipline-specific evaluation strategies. Subsequent modules address the paradigm shift from strict rest to early active rehabilitation, the evidence for targeted interventions in persistent post-concussion symptoms, current pharmacological options, and the structured return-to-activity protocols that form the backbone of safe reintegration into sport, school, and occupational settings. The course concludes with an examination of objective assessment tools, interdisciplinary collaboration models, and the implementation barriers and facilitators that shape real-world concussion management. Throughout this course, particular emphasis is placed on the unique considerations that apply to adolescent populations, who demonstrate longer recovery trajectories and require more conservative management compared to adults. The role of each rehabilitation discipline is woven into every module, ensuring that physical therapists, occupational therapists, and nurses can identify how their specific expertise contributes to optimal patient outcomes within a collaborative care model. All content is grounded in peer-reviewed evidence published primarily between 2022 and 2025, with foundational references included where they represent landmark studies that continue to inform current practice. The scope of this course encompasses the full spectrum of concussion severity, from uncomplicated concussions that resolve within the typical 2 to 4 week window to persistent post-concussion symptoms that may endure for months or longer. Particular attention is devoted to the identification of risk factors for prolonged recovery, including prior concussion history, pre-existing mental health conditions, female sex, and high initial symptom burden, and to the evidence-based interventions that can be mobilized to address persistent symptoms across physical, cognitive, emotional, and occupational domains. The Pharmacological Management module provides a comprehensive review of the current evidence for off-label medications, including methylphenidate, sertraline, guanfacine, and amitriptyline, with practical guidance on clinical decision-making, monitoring, and the integration of pharmacological and non-pharmacological approaches. By the conclusion of this course, you will possess a thorough understanding of the scientific evidence underpinning modern concussion management, the clinical reasoning skills necessary to apply this evidence to individual patient presentations, and the interprofessional communication competencies required to function effectively within a collaborative concussion care team. The learning objectives that follow articulate the specific knowledge and skills that you are expected to demonstrate upon course completion, and they serve as the framework for the multiple-choice examination that accompanies this course. Let us now review the learning objectives for this course. Upon completion, you will be able to accomplish each of the following. First, you will be able to identify the key components and discipline-specific roles of the SCOAT6 and SCAT6 concussion assessment tools. Second, you will be able to differentiate between current evidence-based acute concussion management strategies and outdated approaches, such as strict rest. Third, you will be able to select appropriate targeted interventions for persistent post-concussion symptoms based on identified risk factors. Fourth, you will be able to recognize the current evidence for pharmacological interventions used to manage persistent post-concussion symptoms. Fifth, you will be able to apply the graduated 6-stage return to sport protocol, including symptom threshold criteria and age-specific modifications. Sixth, you will be able to differentiate between cognitive and physical workload demands when planning individualized return to school and return to work protocols. And seventh, you will be able to identify appropriate objective assessment tools for guiding return-to-activity decisions and monitoring concussion recovery. These objectives will guide your learning throughout the course and serve as the foundation for the assessment at the conclusion. Let us now begin with Module 1, which covers the evidence-based approach to concussion assessment. Module 1 focuses on evidence-based concussion assessment, beginning with the multimodal assessment tools that form the foundation of contemporary evaluation. The assessment of concussion in adolescent and adult populations has evolved into a comprehensive, multimodal process that extends well beyond the traditional reliance on symptom checklists and brief cognitive screening. Contemporary best practice, as defined by the Amsterdam Consensus Statement and endorsed by the American Academy of Family Physicians, centers on validated assessment instruments that evaluate physical, cognitive, vestibulo-ocular, cervical, autonomic, and mental health domains in an integrated fashion. Two primary tools anchor the current assessment framework: the Sport Concussion Assessment Tool, or SCAT6, for acute evaluation within the first 72 hours post-injury, and the Sport Concussion Office Assessment Tool, or SCOAT6, for office-based management beyond the acute phase. The SCAT6, designed for use in individuals aged 13 years and older, with the child SCAT6 serving those aged 8 to 12, incorporates multiple assessment domains within a single standardized instrument. Its components include the Post-Concussion Symptom Scale for symptom evaluation, the Standardized Assessment of Concussion, or SAC, for cognitive testing, the Modified Balance Error Scoring System for balance assessment, and a neurological screening examination. Research published in JAMA Network Open demonstrated the diagnostic accuracy of these components through receiver-operator characteristic analyses, confirming that the SAC and symptom scores provide meaningful discriminative value when administered within the first 72 hours after injury. It is essential to recognize, however, that the SCAT6 is not intended to be used in isolation for diagnosis. Rather, it serves as one component of a comprehensive clinical assessment that includes the clinician's overall impression and knowledge of the patient's history. Now let us turn to the SCOAT6 and the critical role of serial assessment in guiding concussion management. The SCOAT6 represents a significant advancement in office-based concussion management, providing clinicians with a structured framework for evaluation and serial monitoring beyond the acute phase. This tool evaluates global symptoms, cognition including 10-word immediate recall and backward digit testing, vestibulo-ocular disturbances, cervical and neurological complications, autonomic dysfunction with orthostatic blood pressure and heart rate testing, balance, sleep quality, anxiety, depression, and graded aerobic exercise tolerance. The SCOAT6 also prompts documentation of prior concussion history, mental health background, and pre-existing headache disorders, all of which are factors that have been identified as significant modifiers of recovery trajectory and management needs. A systematic review informing the development of the SCOAT6 established its role as the most current evidence-informed instrument for guiding management decisions, though it awaits prospective validation. Serial assessment is a cornerstone of evidence-based concussion management. Quantitative symptom scores derived from the SCOAT6 are used to track recovery trajectory over time, with changes in scores guiding decisions about progression through return-to-activity protocols. Reassessment is recommended at least weekly during the first month post-injury and should continue until the patient has successfully reintegrated into pre-injury activities without symptom recurrence. This serial approach enables timely identification of persistent symptoms, allows clinicians to detect risk factors for prolonged recovery, and facilitates appropriate referral to specialist services when indicated. Each rehabilitation discipline brings unique expertise to the concussion assessment process. Let us begin with the physical therapy assessment. Physical therapists bring specialized expertise to the assessment of concussion through their focus on the musculoskeletal, vestibular, and cardiovascular systems. In addition to administering the standard components of the SCOAT6, physical therapists conduct detailed assessments of vestibular function, balance, cervical spine integrity, and aerobic capacity. Vestibular and ocular motor screening evaluates smooth pursuit, saccades, convergence, and the vestibulo-ocular reflex, identifying deficits that may contribute to dizziness, visual disturbance, and difficulty with balance. Dual-task and tandem gait testing provide ecologically valid measures of the patient's ability to manage simultaneous cognitive and motor demands, which is a critical indicator of functional readiness for return to complex activities. Graded exercise testing, often using protocols derived from the Buffalo Concussion Treadmill Test, allows physical therapists to objectively determine the heart rate threshold at which symptom exacerbation occurs, providing a physiological basis for exercise prescription. Orthostatic vital sign assessment evaluates autonomic function, which may be disrupted following concussion and can manifest as exercise intolerance, dizziness upon standing, or cognitive fog. Qualitative research examining experienced clinical decision-making among physical therapists managing concussion has highlighted the importance of clinical reasoning that integrates objective findings with the patient's subjective experience, emphasizing that expert clinicians move beyond protocol-driven assessment to develop individualized clinical hypotheses. Continuing with discipline-specific assessment strategies, let us now examine the contributions of occupational therapists and nurses. Occupational therapists approach concussion assessment through the lens of functional participation, evaluating the impact of injury on the patient's ability to engage in activities of daily living, education, work, play, leisure, and social participation. While occupational therapists may utilize components of the SCOAT6, their assessment extends to cognitive and executive function screening, vision and oculomotor evaluation, sleep assessment, and mental health screening, all framed within the context of the patient's occupational roles and goals. A systematic review of interventions for youth with persistent post-concussion symptoms demonstrated that occupational therapy assessments should identify specific functional limitations that serve as targets for intervention rather than relying solely on symptom scores that may not capture the full impact of concussion on daily life. Goal attainment scaling and motivational interviewing are additional assessment approaches used by occupational therapists to identify barriers to participation and to establish individualized patient-centered treatment goals. These tools facilitate collaborative goal setting that aligns with the patient's values, preferences, and functional needs, and they provide a structured framework for measuring progress over time. The use of these approaches reflects the occupational therapy emphasis on meaningful activity engagement as both a therapeutic medium and an outcome measure. Nurses play a critical role in concussion assessment, particularly in acute care, primary care, and school-based settings where they are often the first healthcare professionals to encounter patients following injury. The nursing assessment encompasses initial screening using the SCAT6 or SCOAT6, ongoing symptom monitoring, identification of red flag symptoms that warrant urgent referral, and comprehensive patient and family education. Nurses are uniquely positioned to assess the broader psychosocial context of the patient's recovery, including family dynamics, access to follow-up care, and adherence to activity modification recommendations. Survey data examining first-line healthcare professional practices in mild traumatic brain injury evaluation and referral have revealed that while there is generally high confidence in diagnosing concussion, there remains limited knowledge of, and referral to, allied health professionals for ongoing management. This finding underscores the importance of nurses serving as care coordinators who facilitate appropriate interdisciplinary referral, ensuring that patients receive comprehensive multimodal care rather than fragmented management by a single discipline. Nurses also monitor for persistent symptoms, screen for emerging mental health concerns such as anxiety, depression, and sleep disturbance, and reinforce the education and reassurance that are foundational to the psychoeducational component of concussion management. Understanding the pathophysiology of concussion is essential for clinicians across all rehabilitation disciplines, as it provides the biological rationale for current management strategies and informs clinical decision-making throughout the recovery process. Concussion is fundamentally a functional rather than structural injury, meaning that conventional neuroimaging, including computed tomography and standard magnetic resonance imaging, typically appears normal despite significant physiological disruption at the cellular level. The pathophysiology is characterized by a complex neurometabolic cascade that begins at the moment of impact and may persist for days to weeks following injury. The biomechanical forces transmitted to the brain during a concussive event produce rapid neuronal membrane deformation, leading to a series of ionic and metabolic disturbances. Mechanosensitive ion channels are disrupted, resulting in an indiscriminate flux of ions across neuronal membranes. Potassium effluxes from cells while sodium and calcium flow inward. This ionic disruption triggers the release of excitatory neurotransmitters, particularly glutamate, which binds to N-methyl-D-aspartate receptors, known as NMDA receptors, and further exacerbates calcium influx. The resulting intracellular calcium accumulation activates a cascade of deleterious processes, including mitochondrial dysfunction, impaired oxidative metabolism, and the generation of reactive oxygen species that contribute to secondary cellular injury. In response to this ionic imbalance, the sodium-potassium adenosine triphosphatase pumps, referred to as the Na plus K plus A to PAS pumps, work at maximum capacity to restore membrane potential, creating a state of significantly increased energy demand. Simultaneously, cerebral blood flow is reduced by approximately 50% from normal levels, a phenomenon that can persist for up to 10 days post-injury, creating a mismatch between the heightened metabolic demand and the diminished energy supply. This energy crisis provides the neurobiological rationale for the acute vulnerability period during which the brain is particularly susceptible to the effects of a second concussive event and during which cognitive and physical exertion should be carefully managed. The neurometabolic cascade also disrupts axonal integrity through impaired axoplasmic flow, potentially contributing to the diffuse axonal injury that underlies many persistent post-concussion symptoms. For physical therapists, this pathophysiological understanding explains why subsymptom threshold aerobic exercise is beneficial. It promotes restoration of cerebral blood flow, autoregulation, and enhances neuroplasticity through upregulation of brain-derived neurotrophic factor without exceeding the brain's limited metabolic capacity. For occupational therapists, the energy crisis model explains why patients experience cognitive fatigue during activities that were previously effortless, and why graduated cognitive loading with strategic rest breaks is essential during the recovery period. For nurses, understanding the neurometabolic cascade provides the foundation for patient education about expected symptoms, recovery timelines, and the rationale for activity modification. Let us now discuss the role of baseline and preseason testing in concussion management. Baseline testing has become an increasingly important component of concussion management, particularly in organized sports settings. Preseason or pre-participation baseline assessments establish individualized normative data for cognitive function, balance, symptom reporting, and vestibulo-ocular motor function, providing clinicians with a critical reference point against which post-injury assessments can be compared. The SCAT6 includes normative data tables that allow clinicians to compare an injured athlete's performance to both population-based norms and, when available, their own pre-injury performance. Baseline testing protocols typically include administration of the complete SCAT6 or SCOAT6, computerized neurocognitive testing using platforms such as the immediate post-concussion assessment and cognitive testing, known as IMPACT, or the Cogstate Brief Battery, the balance error scoring system, and the vestibular ocular motor screening. The utility of baseline testing lies in its ability to detect subtle post-injury changes that might otherwise fall within normal population ranges, but represent a meaningful decline from the individual's pre-injury level of functioning. This is particularly valuable for high-performing individuals whose post-injury scores might still appear normal on standardized measures, despite representing significant cognitive decline from their personal baseline. However, the limitations of baseline testing must be acknowledged. Baseline assessments have a finite useful lifespan, generally 1 to 2 years, after which cognitive development in adolescence and natural variability may render the baseline data unreliable. Additionally, some athletes may intentionally perform poorly on baseline testing in an effort to make post-injury testing appear closer to normal, though this practice has been increasingly addressed through validity indicators embedded in modern testing platforms. Despite these limitations, the Amsterdam Consensus Statement endorses baseline testing as a useful but not essential component of concussion assessment, emphasizing that the absence of baseline data should not delay or impair clinical evaluation and management. The clinical examination for concussion extends beyond standardized assessment tools and plays a vital role in differential diagnosis. The clinical examination encompasses a thorough neurological screening that evaluates cranial nerve function, motor and sensory integrity, reflexes, and coordination. The neurological examination serves a dual purpose. It provides additional data points for the concussion diagnosis, and critically, it screens for more serious intracranial pathology that may present with overlapping symptoms. Clinicians must systematically evaluate for focal neurological deficits, including unilateral weakness, asymmetric reflexes, visual field cuts, and cranial nerve palsies that would suggest structural injury rather than functional concussion, and would warrant emergent neuroimaging and neurosurgical consultation. Differential diagnosis in the acute setting includes cervical spine injury, vestibular disorders, migraine, psychiatric conditions including conversion disorder and acute stress reaction, and systemic conditions such as dehydration and heat illness that may mimic concussion symptoms. The overlap between concussion and cervicogenic symptoms is particularly important, as the mechanisms that produce concussive brain injury often simultaneously injure the cervical spine. Cervical pathology can produce headache, dizziness, visual disturbance, and cognitive difficulty that are clinically indistinguishable from primary concussion symptoms without careful physical examination. Physical therapists play an essential role in this differential diagnosis through their expertise in cervical spine examination, which enables them to identify cervicogenic contributors and ensure that these are appropriately managed alongside the primary concussion. To conclude Module 1, let us examine the epidemiology and population-specific incidence patterns of concussion. The epidemiology of concussion reveals substantial variation across populations, settings, and injury mechanisms that has important implications for clinical practice and public health planning. In the United States, an estimated 1.6 to 3.8 million sport and recreation-related concussions occur annually, though these figures are widely regarded as underestimates due to underreporting by athletes and inconsistent diagnostic practices across clinical settings. Emergency department data indicate that concussion-related visits have increased by 43% over the past decade, likely reflecting a combination of true incidence increases and improved recognition and reporting, rather than a simple rise in injury rates. Among sport-specific populations, concussion incidence varies considerably. In American football, the concussion rate is approximately 6.71 per 10,000 athlete exposures, while in women's soccer it ranges from 3.0 to 7.3 per 10,000 exposures. Ice hockey, rugby, and lacrosse also carry elevated concussion risks. Beyond organized sports, concussion occurs frequently in recreational activities, falls, particularly in older adults, motor vehicle accidents, and workplace injuries. The age distribution of concussion is bimodal, with peaks in the adolescent population aged 15 to 19 years and in older adults aged 65 years and above, each of which presents distinct clinical challenges and management considerations. For adolescents, the combination of high participation rates in contact sports, ongoing brain development, and psychosocial factors creates a uniquely vulnerable population that requires specialized management approaches as detailed throughout this course. Module 2 examines the acute management of concussion, beginning with one of the most significant paradigm shifts in the history of concussion care. Perhaps no aspect of concussion management has changed more dramatically in recent years than the approach to the acute phase of injury. For decades, the prevailing clinical recommendation was strict cognitive and physical rest, often referred to as cocooning, until complete symptom resolution. Patients were routinely advised to remain in darkened rooms, avoid all screens, limit social interaction, and abstain from any form of physical or cognitive activity. This approach, while intuitively appealing, was not supported by high-quality evidence and has now been definitively replaced by an active recovery model endorsed by the Amsterdam Consensus Statement, the American Academy of Family Physicians, and multiple international consensus groups. The evidence against prolonged strict rest is compelling. A landmark randomized controlled trial involving 99 participants with a median age of 14 years demonstrated that strict rest for 5 days did not result in better neurocognitive function or balance at 10 days compared to usual care consisting of 1 to 2 days of rest, followed by stepwise return to activity. Furthermore, accumulating evidence indicates that prolonged cognitive rest and minimal reduction in physical activity after concussion are themselves risk factors for prolonged recovery, potentially predisposing patients to secondary symptoms of fatigue, reactive depression, physiological deconditioning, and delayed healing. These findings have fundamentally altered clinical practice, with current guidelines now recommending a brief period of relative rest, typically 24 to 48 hours, followed by early, symptom-guided return to both physical and cognitive activities. Let us now examine the specifics of relative rest and early activity initiation during the acute phase. The current consensus recommends up to 48 hours of relative rest following concussion, during which patients should limit activities of daily living and reduce screen time but should not be confined to bed rest or complete inactivity. During this initial period, light, sub-symptom threshold physical activity such as walking is not only permitted but encouraged, provided it does not provoke more than mild exacerbation of symptoms. The distinction between relative rest and strict rest is clinically important. Relative rest acknowledges that some degree of activity is both safe and potentially beneficial, while strict rest imposes unnecessarily restrictive limitations that may delay recovery. Early subsymptom threshold aerobic exercise, initiated within 24 to 72 hours post-injury, represents one of the most significant advances in acute concussion management. A prospective cohort study of 726 children and adolescents found that 69.5% participated in physical activity within 7 days of concussion, primarily light aerobic exercise, and this early resumption was associated with a lower risk of persistent post-concussive symptoms compared with no physical activity. A systematic review of 22 studies evaluating physical activity following sport-related concussion in adolescents confirmed that daily physical activity, or active rehabilitation programs, led to a reduction in symptoms and a decrease in the number of days to medical clearance, with sufficient evidence to recommend exercise as an appropriate therapy for individuals with acute concussion. The exercise prescription in the acute phase follows a model derived from cardiac rehabilitation. Exercise intensity is titrated to the heart rate threshold at which symptoms worsen, with initial activity prescribed at no more than 55% of estimated maximum heart rate for light activity and no more than 70% for moderate activity, using the formula 220 minus the patient's age to estimate maximum heart rate. Patients may increase their activity intensity as often as every 24 hours based on symptom response during previous exercise sessions, with progression continuing as long as symptom exacerbations remain mild, meaning no more than a 2-point increase on a 0 to 10 scale, and brief, resolving within 1 hour. Understanding the proposed mechanisms of early exercise helps explain why this approach accelerates recovery. The biological rationale for early exercise after concussion centers on its effects on neuroplasticity and cardio-regulatory mechanisms. Concussion disrupts autonomic nervous system function and cerebral blood flow autoregulation, and exercise intolerance is recognized as an objective physiological sign of acute concussion that reflects these impairments. Subsymptom threshold aerobic exercise is hypothesized to promote recovery by improving autonomic function, normalizing cerebral blood flow regulation, enhancing neuroplasticity through the upregulation of brain-derived neurotrophic factor, and providing mood-enhancing effects that counteract the psychological burden of injury and activity restriction. Studies have demonstrated that rest exceeding 3 days post-injury was similarly or less effective than treatment regimens, allowing for earlier participation in physical activity, and that if prolonged, rest may predispose to secondary symptoms that compound the original concussion-related impairments. Psychoeducation and expectation management represent some of the most impactful interventions available in the acute phase of concussion care. Psychoeducation, defined as the provision of structured information about the nature of concussion, expected recovery timelines, and evidence-based management strategies, is recognized as one of the most impactful interventions in the acute phase. A systematic review and meta-analysis published in JAMA Network Open classified early provision of information and advice as having the strongest evidence among non-pharmacological interventions for preventing persistent symptoms, with the recommendation that this intervention begin within the first 4 weeks after injury. The content of psychoeducation should include a clear explanation of what concussion is and is not, reassurance about the expected positive prognosis with the majority of patients recovering within 2 to 4 weeks, practical guidance on graduated return to activities, and normalization of common symptoms such as headache, fatigue, and cognitive difficulty. Managing patient and family expectations is a critical component of acute psychoeducation, as catastrophic thinking about injury consequences has been identified as a risk factor for prolonged recovery. Patients who believe their concussion will result in long-term disability or who interpret normal recovery symptoms as evidence of serious brain damage may develop anxiety and hypervigilance that perpetuate symptom reporting and avoidance behaviors. Conversely, patients who receive early reassurance about the expected positive trajectory of recovery, combined with practical strategies for symptom management, demonstrate faster recovery and lower rates of persistent symptoms. This psychoeducational approach aligns with cognitive behavioral principles and can be delivered effectively by any member of the clinical team, making it accessible across practice settings regardless of the availability of specialized concussion providers. Each discipline plays a distinct role in acute concussion management. Let us begin with the physical therapist's contribution. Physical therapists are integral to acute concussion management through their expertise in musculoskeletal and vestibular assessment, exercise prescription, and patient education. In the acute phase, physical therapists assess balance, gait, and vestibular function using standardized tools including the SCAT6 and the vestibular ocular motor screening. They guide patients through the transition from brief relative rest to a stepwise, individualized return to physical activity, ensuring that exercise intensity is appropriately calibrated to the patient's symptom threshold. Physical therapists are specifically trained to avoid the extremes of both strict rest and premature return to vigorous activity, recognizing that the optimal approach lies in carefully titrated progressive loading of the cardiovascular, vestibular, and musculoskeletal systems. Early identification of cervical spine involvement is another important contribution of physical therapy in the acute phase. Because many sport-related concussions occur through mechanisms that also produce whiplash-type cervical injury, cervical strains are commonly associated with concussion and may contribute to headaches, dizziness, and neck pain that overlap with and complicate the concussion symptom profile. Physical therapists are uniquely qualified to differentiate cervicogenic contributions from primary concussion symptoms and to initiate appropriate cervical management when indicated. Occupational therapists and nurses also make essential contributions during the acute phase. While occupational therapists may have a less prominent role in the immediate acute phase compared to physical therapists, their early involvement contributes to comprehensive care through identification of barriers to participation and provision of psychoeducation. Occupational therapists help patients understand the relationship between their symptoms and functional limitations, providing practical strategies for managing cognitive and sensory demands during the relative rest period and the early return to activity. Their focus on the patient's occupational roles, including education, work, leisure, and social participation, ensures that the broader functional impact of concussion is addressed from the outset, rather than being deferred until symptoms persist. Nurses are frequently the first point of contact for patients with concussion, particularly in emergency departments, urgent care settings, and school health offices. Their acute phase responsibilities encompass initial screening and symptom documentation, education and reassurance for both the patient and family, and coordination of follow-up care. Nurses reinforce the current evidence-based message that brief relative rest followed by gradual return to activity is preferred over prolonged inactivity, and they provide written instructions outlining expected recovery timelines, warning signs requiring urgent reevaluation, and contact information for follow-up appointments. For adolescent patients, nurses play a particularly important role in facilitating communication between healthcare providers, families, and schools. They may initiate the process of academic accommodation by documenting the concussion diagnosis and providing school personnel with guidance on appropriate modifications to the student's schedule and workload. Nurses also monitor for risk factors that may warrant a more conservative management approach, including a history of prior concussions, pre-existing mental health conditions, and high initial symptom burden. The emerging evidence on early aerobic exercise raises important questions about the optimal exercise dose that maximizes recovery while minimizing risk. Current consensus recommendations suggest that aerobic exercise should be initiated within 24 to 72 hours post-injury at a light to moderate intensity performed daily or near daily, and titrated based on the individual's symptom response. The exercise session duration during the acute phase typically ranges from 15 to 30 minutes, with gradual increases as tolerance improves. Importantly, the evidence suggests that the act of engaging in regular physical activity may be as important as the specific exercise parameters, with the consistency of daily activity providing ongoing stimulus for the neuroplastic and cardiovascular recovery processes. The clinical determination of when a patient is exercising at an appropriate intensity requires integration of multiple data sources, including heart rate monitoring, subjective symptom ratings during and after exercise, ratings of perceived exertion, and clinical observation of the patient's exercise tolerance and recovery patterns. Physical therapists are ideally positioned to make these clinical judgments given their training in exercise physiology, biomechanics, and symptom-guided activity progression. The use of heart rate monitors during prescribed exercise sessions provides objective data that supplements subjective reporting and enables more precise titration of exercise intensity across subsequent sessions. Adolescents represent a unique population in the context of acute concussion management, requiring additional considerations that reflect their developmental stage, psychosocial context, and recovery patterns. The developing adolescent brain is characterized by ongoing myelination, synaptic pruning, and prefrontal cortex maturation, processes that may both increase vulnerability to concussive injury and influence the trajectory of recovery. Research consistently demonstrates that adolescents aged 13 to 17 years experience longer recovery times compared to both younger children and adults, with median time to symptom resolution of 14 days compared to 12 days in younger children. This extended recovery trajectory necessitates a more conservative approach to activity progression and return to activity decision-making. The psychosocial dimensions of acute concussion management are particularly salient for adolescents, for whom identity formation, peer relationships, and academic achievement are central developmental tasks. Removal from sports participation, social isolation during the relative rest period, and the inability to engage in normal school activities can produce significant psychological distress that may compound the primary concussion symptoms. Clinicians must balance the need for appropriate activity modification with the recognition that excessive restriction may be counterproductive, contributing to reactive depression, anxiety, and a prolonged sense of disconnection from peers and normal routines. Communication between healthcare providers, families, and schools is a critical component of adolescent acute concussion management. Parents and caregivers often express anxiety about the potential for long-term consequences, and they require clear, evidence-based information about expected recovery timelines, appropriate activity levels, and warning signs that warrant medical reevaluation. School personnel, including teachers, counselors, and administrators, need specific guidance regarding academic accommodations, and this communication should ideally be initiated within the first few days of injury to ensure that appropriate supports are in place when the student begins the return-to-learn process. Nurses and occupational therapists are particularly well positioned to facilitate this school provider communication, given their expertise in functional assessment and their established roles within educational and healthcare settings. While the vast majority of concussions resolve without complications, clinicians must remain vigilant for red flag presentations that suggest a more serious injury. Red flag symptoms that warrant urgent referral to an emergency department include worsening headache, repeated vomiting, seizures, focal neurological deficits such as weakness or numbness in the extremities, slurred speech, increasing confusion or disorientation, unusual behavioral changes, and loss of consciousness lasting more than 1 minute. Any deterioration in the patient's level of consciousness, including increasing drowsiness, difficulty being aroused, or failure to recognize familiar people or places, should prompt immediate emergency evaluation, as these findings may indicate the development of an intracranial hemorrhage or other structural pathology. The Canadian CT head rule and similar clinical decision tools provide structured criteria for determining when neuroimaging is indicated in the acute setting. However, clinicians should recognize that these tools are designed to identify patients who require computed tomography scanning to rule out neurosurgical emergencies, and a normal CT scan does not exclude the diagnosis of concussion. Indeed, the hallmark of concussion is a functional disturbance that occurs in the absence of detectable structural abnormality on conventional imaging. Clinicians across all disciplines should ensure that patients and families receive clear written and verbal instructions regarding red flag symptoms, and these instructions should include specific guidance about when and how to seek emergency care. Follow-up assessment within 1 to 2 weeks of injury is recommended for all patients to monitor symptom trajectory and ensure appropriate progression through return-to-activity protocols. Systematic clinical monitoring during the acute phase establishes the foundation for evidence-based progression through return-to-activity protocols. Serial assessment using validated symptom scales, particularly the post-concussion symptom scale within the SCAT6 and the comprehensive SCOAT6, provides quantitative data that enables objective tracking of recovery trajectories. During the first week post-injury, daily symptom monitoring is recommended, with patients recording the presence and severity of symptoms at consistent times of day. This daily monitoring captures the natural fluctuations in symptom intensity that characterize acute concussion recovery and provides clinicians with a granular view of the patient's response to activity modification strategies. Physical therapists may implement structured activity logs that document the type, duration, and intensity of physical activity alongside concurrent symptom ratings, enabling precise identification of the symptom exacerbation threshold and facilitating individualized exercise prescription. Occupational therapists may similarly track cognitive activity tolerance, documenting the duration and type of cognitive tasks the patient is able to sustain before experiencing symptom exacerbation. This dual tracking of physical and cognitive exertion thresholds provides a comprehensive picture of the patient's functional capacity and supports coordinated, interdisciplinary decision-making about the pace and sequencing of return to activity progression. Nurses contribute to monitoring through structured telephone follow-up, telehealth check-ins, and in-person reassessment, ensuring continuity of care and early identification of patients who may be at risk for persistent symptoms or who require referral to specialist services. Module 3 addresses the management of persistent post-concussion symptoms, beginning with a review of the prevalence, definitions, and risk factors that inform clinical decision-making. While the majority of individuals with concussion recover within the first 2 to 4 weeks, a clinically significant subset develops persistent post-concussion symptoms referred to as PPCS that extend well beyond the expected recovery window. Current evidence indicates that post-concussion symptoms gradually resolve in most patients during the first 12 weeks, with 80 to 85% recovering within 3 to 6 months. However, 30% of patients experience new onset or intensification of at least one symptom at 3 months, and between 5 and 20% continue to experience symptoms at 12 months after injury. This contrasts sharply with sport-related concussion in athletes, where 80 to 90% typically recover within 7 to 10 days after their first injury, suggesting that non-athletic populations, including workers in cognitively demanding professions, may have substantially longer recovery trajectories. Recent large-scale research has provided important insights into the risk factors that predict persistent symptoms. A study published in JAMA Network Open, examining factors associated with persisting symptoms after concussion in adults, found that cognitive symptoms, particularly difficulty concentrating, are associated with the greatest odds of persistent symptoms at both 1 month, with an adjusted odds ratio of 3.12, and 6 months, with an adjusted odds ratio of 26.81 post-injury. Individuals who reported difficulty concentrating acutely after concussion were 3 times more likely to develop persistent post-concussion symptoms. Medical history of anxiety, depression, or sleep disorders emerged as the second strongest predictor, with individuals approximately 3 times more likely to develop persistent symptoms at 3 months. Acute physical symptoms including headache, nausea, dizziness, and sensory sensitivity were also associated with increased risk, with an adjusted odds ratio of 1.98 at 3 months, and female sex emerged as a consistent factor across all time points. Interestingly, age has not emerged as a strong independent risk factor for persisting symptoms when treated as a continuous variable, though categorical analyses reveal nuanced patterns. A comparison of multi-domain assessment outcomes between middle-aged adults, those 50 to 59 years old, and older adults aged 60 years and above following concussion revealed a paradoxical finding. Older adults demonstrated lower odds of impairment on verbal memory, with an odds ratio of 0.05 visual motor speed, with an odds ratio of 0.08 in reaction time, with an odds ratio of 0.21 compared to the middle-aged group. This suggests that the 50 to 59 age range may represent a particularly vulnerable period for cognitive recovery following concussion, though the mechanisms underlying this pattern remain unclear. Cervicovestibular rehabilitation represents the most strongly supported targeted intervention for individuals with persistent dizziness, neck pain, and headaches following concussion. A landmark randomized controlled trial demonstrated that participants receiving combined cervical and vestibular physical therapy were 3.91 times more likely to achieve medical clearance within 8 weeks compared to those managed with rest, followed by gradual exertion, and 2.91 times more likely compared to a subtherapeutic intervention. In the treatment group, 73% of participants were medically cleared within 8 weeks, compared to only 7% in the control group. A systematic review published in the British Journal of Sports Medicine confirmed that cervicovestibular rehabilitation is recommended for adolescents and adults with dizziness, neck pain, or headaches persisting beyond 10 days after concussion. The cervical component of this intervention is particularly important given the high prevalence of cervicogenic symptoms following concussion. A systematic review examining the role of cervical symptoms in post-concussion management found that neck pain at initial evaluation increases the risk of developing persistent symptoms by 2.58 to 6.38 times, and that cervicogenic symptoms are present in 7 to 69% of acute cases, rising to 90% in patients with persistent symptoms. Treatment using graded cervical manual therapy has been shown to reduce time to symptom resolution and medical clearance. For patients with vestibular symptoms or impairments persisting beyond 5 days, vestibular rehabilitation is recommended as a targeted intervention. A meta-analysis of vestibular rehabilitation therapy for mild traumatic brain injury demonstrated significant improvement in perceived dizziness, as measured by the Dizziness Handicap Inventory, with a standardized mean difference of -0.33. The meta-analysis also showed significant reduction in vestibular ocular motor screening scores, with a standardized mean difference of -0.40, and significant reduction in post-concussion symptom scale scores, with a standardized mean difference of -0.39. A randomized controlled trial of precision vestibular rehabilitation in adolescents aged 12 to 18 years demonstrated that targeted vestibular intervention produced significantly greater improvement in horizontal vestibulo-ocular reflex and vertical vestibulo-ocular reflex compared to behavioral management alone. Critically, earlier referral to vestibular therapy is associated with faster recovery. In athletes with sport-related concussion referred for vestibular therapy, earlier referral was significantly predictive of shorter days to symptom resolution and shorter time to return to play. Vestibular therapy should focus on specific deficits identified during assessment and should employ an expose-recover model delivered by clinicians with expertise in vestibular rehabilitation. Psychological interventions, particularly cognitive behavioral therapy and collaborative care models, have emerged as important components of persistent post-concussion symptom management. The largest randomized controlled trial of collaborative care with embedded cognitive behavioral therapy, or CBT, enrolled 200 adolescents with a mean age of 14.7 years, of whom 62% were female, with persistent symptoms at least 1 month after injury. Adolescents receiving collaborative care reported fewer post-concussion symptoms at 3 months, with a 3.4-point decrease on the Health Behavior Inventory, and at 12 months with a 4.1-point decrease. They also showed higher health-related quality of life at 12 months and improved sleep quality at 3, 6, and 12 months. At 6 months post-baseline, only 13.0% of intervention patients reported high levels of post-concussive symptoms, compared with 41.7% of control patients. A brief cognitive behavioral intervention program averaging 4 sessions, which included concussion education, activity scheduling, sleep hygiene, relaxation training, and cognitive restructuring, demonstrated significant symptom improvement in children and adolescents aged 10 to 18 years with persistent symptoms. The largest change occurred between sessions 2 and 3, following the session focusing on concussion psychoeducation and sleep hygiene. For individuals with prolonged post-concussion symptoms lasting more than 12 months, a systematic review found that CBT appears to have the strongest evidence base for improving anxiety, anger, and overall mental well-being, though the evidence base remains limited and requires more robust methodological designs. The evidence supports individually tailored, multimodal interventions as the most effective approach for patients with persistent post-concussion symptoms. Individually tailored, presentation-specific multimodal interventions that combine cervical, vestibular, and oculomotor therapy demonstrate the strongest overall effects for patients with persistent symptoms. A systematic review and meta-analysis found that concussed individuals with persistent symptoms beyond 2 weeks were approximately 3 times more likely to have returned to sport by 8 weeks if they received multimodal interventions, and that multimodal interventions had a moderate effect in improving symptom scores, with a standardized mean difference of 0.63. Subsymptom threshold aerobic exercise, when used as a component of multimodal rehabilitation, has a moderate effect in improving symptom scores, with a standardized mean difference of 0.43 and is effective regardless of initial symptom burden. Comprehensive cognitive rehabilitation represents another critical element of multimodal care for patients with persistent cognitive impairment affecting memory, attention, or executive functions. Specialized clinician-directed cognitive rehabilitation interventions demonstrate superior outcomes compared to usual care or self-directed computerized brain training. Importantly, self-managed computerized cognitive training does not result in meaningful or sustained improvement in cognitive function and has been associated with worse cognitive and neurobehavioral outcomes, underscoring the necessity of clinician-directed approaches. Effective cognitive rehabilitation includes compensatory cognitive training, environmental modifications to facilitate attention, and establishing new techniques for organization and note-taking. Short-term trials of evidence-based cognitive rehabilitation spanning 4 to 6 sessions may provide sufficient information to determine potential benefit from further treatment, while prolonged trials that perpetuate dependence and a sick role are strongly discouraged. Early provision of information and psychoeducation, tailored to individual patient needs and delivered over an extended period, is recommended as a foundational intervention for both preventing and managing persistent post-concussion symptoms. This approach should begin within 4 weeks after injury and continue throughout recovery, addressing expectations, symptom management strategies, and the graduated resumption of cognitive and physical activities. A systematic review and guideline recommendation published in JAMA Network Open classified early information and advice as having the strongest evidence among non-pharmacological interventions for persistent symptoms in adults. Oculomotor dysfunction is among the most prevalent and functionally disabling consequences of concussion, affecting an estimated 50 to 90% of patients with persistent post-concussion symptoms. Visual symptoms including blurred vision, difficulty reading, light sensitivity, convergence insufficiency, and impaired smooth pursuit and saccadic eye movements can significantly impair academic performance, occupational functioning, and quality of life. Oculomotor rehabilitation delivered by optometrists, occupational therapists, or physical therapists with specialized training in vision therapy targets specific deficits identified during the vestibular ocular motor screening and comprehensive oculomotor assessment. Convergence insufficiency, characterized by the inability to maintain binocular alignment during near vision tasks, is particularly common after concussion and contributes to difficulty with reading, screen use, and any task requiring sustained near-point visual focus. Evidence-based treatment for post-concussion convergence insufficiency includes pencil push-ups, Brock string exercises, stereogram cards, and computer-based vergence training programs. A systematic review of targeted interventions confirmed that vision rehabilitation for oculomotor deficits is associated with improvement in visual symptoms and functional visual performance, though the evidence base would benefit from larger randomized controlled trials with standardized outcome measures. For occupational therapists, oculomotor rehabilitation represents a natural extension of their expertise in visual perceptual assessment and functional vision intervention. Occupational therapists evaluate the impact of visual dysfunction on daily activities such as reading, writing, driving, meal preparation, and screen-based work, and they design intervention programs that integrate oculomotor exercises with functional task training in the patient's real-world environment. Physical therapists contribute to oculomotor rehabilitation through their expertise in vestibulo-ocular reflex training and gaze stabilization exercises, which address the overlap between vestibular and oculomotor dysfunction that is common in the post-concussion population. Interprofessional collaboration between vision specialists, physical therapists, and occupational therapists is essential for patients with complex visual vestibular presentations. Sleep disturbance is reported by 30 to 70% of individuals following concussion and represents both a symptom of concussion and a significant barrier to recovery. Disrupted sleep impairs the neuroplastic processes that are essential for brain recovery, reduces pain thresholds, exacerbates mood disturbance, and impairs cognitive function, creating a vicious cycle in which poor sleep perpetuates and intensifies other post-concussion symptoms. The relationship between sleep and concussion recovery is bidirectional. Concussion disrupts the neural circuits that regulate sleep-wake cycles, while the resulting sleep deprivation further impairs the neural recovery processes. Non-pharmacological sleep interventions represent the first line of treatment for post-concussion sleep disturbance and include sleep hygiene education, stimulus control therapy, sleep restriction therapy, and cognitive behavioral therapy for insomnia, known as CBTI. Sleep hygiene education encompasses guidance on maintaining consistent sleep and wake times, creating an optimal sleep environment with reduced light and noise, limiting screen exposure in the hours before bedtime due to the melatonin-suppressing effects of blue light, avoiding caffeine and stimulating activities in the evening, and establishing a relaxing pre-sleep routine. The collaborative care trial by McCarty and colleagues demonstrated that sleep quality improvements were among the earliest and most consistent benefits of the intervention, with significant improvement observed at 3, 6, and 12 months post-baseline. For patients with persistent sleep disturbance that does not respond adequately to behavioral interventions, pharmacological options may be considered. Low-dose melatonin, at 0.5 to 5 milligrams administered 30 to 60 minutes before the desired bedtime, is the most commonly recommended first-line pharmacological agent for post-concussion insomnia, given its favorable side effect profile and its role in regulating circadian rhythm disruption. Clinicians should be cautious with sedative hypnotic medications in the post-concussion population, as these agents may impair cognitive function, increase fall risk, and mask the natural recovery trajectory. The guidelines recommend that sleep management should be incorporated into the comprehensive treatment plan for all patients with persistent post-concussion symptoms, and that sleep assessment should be conducted at every clinical encounter using validated instruments such as the Pittsburgh Sleep Quality Index or the Insomnia Severity Index. The management of persistent post-concussion symptoms exemplifies the importance of interdisciplinary collaboration, as the multifaceted nature of these symptoms requires the complementary expertise of multiple rehabilitation disciplines working in coordination. Physical therapists serve as primary providers for cervicovestibular rehabilitation, exercise prescription, and the graduated return to physical activity, addressing the musculoskeletal, vestibular, and cardiovascular dimensions of persistent symptoms. Their role extends beyond targeted rehabilitation to include the ongoing assessment of exertional tolerance, the identification of new or evolving physical impairments, and the communication of functional progress to the interdisciplinary team. Occupational therapists address the impact of persistent symptoms on the patient's engagement in meaningful activities, providing cognitive rehabilitation, visual perceptual intervention, energy conservation and activity pacing strategies, environmental modification, and vocational rehabilitation. Their unique perspective on the interaction between the individual, the environment, and the occupation enables them to design intervention programs that are ecologically valid, targeting the specific functional challenges that the patient encounters in their daily life, rather than relying solely on impairment-level exercises. Goal attainment scaling and motivational interviewing, as assessment and intervention tools, support patient-centered care and promote self-efficacy in the recovery process. Nurses contribute to persistent symptom management through ongoing monitoring, care coordination, medication management education, and psychosocial support. Their role is particularly important in primary care settings, where they may serve as the patient's primary point of contact and the coordinator of referrals to specialist services. Nurses also play a critical role in screening for comorbid conditions that may complicate recovery, including depression, anxiety, post-traumatic stress disorder, and substance use disorders, ensuring that these conditions are identified and addressed within the comprehensive management plan. The integration of mental health screening into routine nursing assessment represents an important opportunity to improve outcomes for patients with persistent symptoms, given the strong evidence linking pre-existing and post-injury mental health conditions to prolonged recovery. Module 4 examines the pharmacological interventions available for managing persistent post-concussion symptoms, beginning with an overview of the current pharmacological landscape. No medications have received FDA approval specifically for the treatment of post-concussion symptoms, and all pharmacological interventions in this context are used off-label. Despite this limitation, a growing body of evidence supports the judicious use of selected agents for specific symptom domains, particularly cognitive dysfunction, mood disturbance, and post-traumatic headache, when these symptoms persist beyond the expected recovery window and are not adequately addressed by non-pharmacological interventions alone. A systematic review published in JAMA Neurology examined the association of pharmacological interventions with symptom burden reduction in patients with mild traumatic brain injury, providing the most comprehensive synthesis of the available evidence to date. The overarching principle guiding pharmacological management is to start low and go slow, initiating medications at low doses and titrating gradually to minimize side effects, which may be particularly pronounced in patients whose neurological function is already compromised by concussion. Methylphenidate is the most well-supported pharmacological agent for treating cognitive dysfunction following mild traumatic brain injury, particularly deficits in attention, processing speed, and executive function. A meta-analysis and meta-regression examining pharmacotherapy to improve cognitive functioning after acquired brain injury found that methylphenidate showed a small but statistically significant positive effect on cognitive functioning, with an effect size of 0.34. Improvements were demonstrated in executive memory, baseline speed, inhibitory control, and variability in responding. Treatment regimens ranging from 4 weeks to 30 weeks demonstrated benefits for cognitive dysfunction, depression, and fatigue after mild traumatic brain injury. The cognitive domains most responsive to methylphenidate, namely attention, processing speed, and executive function, are precisely those most critical for workers in cognitively demanding occupations such as healthcare, education, information technology, and management roles. For these populations, even modest improvements in cognitive function may translate into meaningful gains in occupational performance and the ability to return to work. However, clinicians must carefully weigh these benefits against the potential for side effects, which include insomnia, decreased appetite, headache, anxiety, increased heart rate and blood pressure, and the potential for abuse or dependence. Insomnia and anxiety are particularly concerning in the post-concussion population, as these symptoms may already be elevated and could be exacerbated by stimulant medication. Pharmacological management in the adolescent population requires additional caution and consideration due to the unique characteristics of the developing brain. The developing brain may respond differently to psychoactive medications compared to adults. The FDA black box warning on antidepressants regarding increased suicidality risk in children and adolescents applies to the use of selective serotonin reuptake inhibitors for post-concussion mood disturbance, and clinicians must carefully weigh the potential benefits against this risk. Methylphenidate and other stimulant medications must be prescribed with attention to the potential for misuse in school and college settings, where stimulant diversion is a recognized concern. Adolescent patients and their families should receive thorough education about the rationale for pharmacological treatment, expected benefits and timelines, potential side effects, and the importance of medication compliance and regular follow-up monitoring. The decision to initiate pharmacological treatment in adolescents should generally involve a collaborative discussion among the patient, parents, or guardians, and the treating clinician, with clear documentation of informed consent. Baseline assessments of mood, sleep, cognitive function, and academic performance should be obtained before starting medication to enable objective evaluation of treatment response. For adolescents participating in organized sports, clinicians must also consider whether any prescribed medications appear on prohibited substance lists for their sports governing body, and appropriate therapeutic use exemption documentation should be completed when necessary. Sertraline is the most commonly studied selective serotonin reuptake inhibitor, or SSRI, for the treatment of post-injury depression and has the strongest evidence base among antidepressants for this indication. Studies report that sertraline treatment over 4 to 8 weeks is associated with reductions in depression, aggression, and anger, and improvements in global function. Notably, pharmacological treatment for depression at the time of concussion may be associated with significantly fewer clinician visits for concussion symptoms at 3, 6, and 12 months after injury, suggesting that effective mood management may have broader effects on overall symptom recovery. The decision to initiate SSRI therapy should be informed by a comprehensive assessment of the patient's mood symptoms, their impact on daily functioning and recovery, and the presence of pre-injury mood disorders that may have been exacerbated by the concussion. Common side effects of SSRIs, including nausea, sexual dysfunction, weight gain, drowsiness, and initial anxiety exacerbation, must be discussed with patients and monitored closely. For patients who are simultaneously participating in active rehabilitation programs, drowsiness and fatigue-related side effects may interfere with exercise tolerance and engagement in cognitive tasks, necessitating careful timing of medication administration and ongoing communication between prescribers and rehabilitation providers. The relationship between depression and concussion recovery is bidirectional and complex. Pre-existing depression is a well-established risk factor for prolonged post-concussion symptoms, while the functional limitations, social isolation, and activity restriction that accompany concussion can precipitate or exacerbate depressive symptoms. Pharmacological treatment of depression at the time of concussion may be associated with significantly fewer clinician visits for concussion symptoms at 3, 6, and 12 months after injury, suggesting that effective mood management has broader effects on overall symptom recovery. For patients with mild to moderate depressive symptoms, structured exercise programs and cognitive behavioral therapy should be considered as first-line interventions, with SSRIs reserved for patients with moderate to severe symptoms or those who do not respond adequately to non-pharmacological approaches. Let us now discuss anxiety management and additional pharmacological agents that address cognitive dysfunction in persistent post-concussion symptoms. Anxiety is a prevalent comorbidity following concussion, reported by 15 to 30% of patients in the acute phase and persisting in a subset of those with prolonged recovery. Post-concussion anxiety may manifest as generalized anxiety, health anxiety focused on injury consequences, specific phobias related to the activity during which the concussion occurred, or avoidance behaviors that interfere with rehabilitation participation and return to activity. While cognitive behavioral therapy remains the first-line treatment for post-concussion anxiety, pharmacological management may be indicated for patients with severe or debilitating anxiety that limits their ability to engage in rehabilitation or daily activities. SSRIs are considered first-line pharmacological agents for post-concussion anxiety, given their established efficacy for generalized anxiety disorder and their relatively favorable side effect profile. Buspirone, a serotonin 5-HT1, a partial agonist, represents an alternative anxiolytic that may be considered for patients with post-concussion anxiety who do not tolerate SSRIs or for whom SSRIs are contraindicated. Benzodiazepines are generally contraindicated in the post-concussion population due to their sedating effects, potential for cognitive impairment, and risk of dependence, and they should be avoided unless specifically indicated for a concurrent condition and prescribed with close monitoring. For patients presenting with irritability and emotional lability following concussion, which may reflect disruption of frontal limbic circuitry rather than a primary mood disorder, low-dose SSRIs or guanfacine may provide symptomatic relief while the underlying neural circuits recover. Guanfacine, an alpha-2 adrenergic receptor agonist, has demonstrated substantial improvements in working memory among participants with mild traumatic brain injury, with working memory levels reaching those of healthy participants in one study. This agent may be particularly relevant for individuals requiring sustained attention and complex problem-solving in their occupational roles. The primary side effects of guanfacine include sedation, dry mouth, constipation, and hypotension, which may limit its use in patients who require alertness and physical activity as part of their rehabilitation program. Donepezil, a cholinesterase inhibitor more commonly associated with the treatment of Alzheimer's disease, showed a large effect size for cognitive improvement, with D equals 1.68 in a limited number of studies examining its use in mild traumatic brain injury. In an open-label study, 4 of 6 patients with mild traumatic brain injury and chronic post-concussion syndrome reported improvements in memory or cognition. 2 began working part-time, and 5 experienced improvements in clinical global function. While these results are promising, the small sample sizes and open-label design preclude definitive conclusions, and further randomized controlled trials are needed before donepezil can be recommended as a standard treatment. Amitriptyline and related agents play an important role in the management of persistent post-traumatic headaches and sleep disturbance. Amitriptyline, a tricyclic antidepressant with established efficacy in migraine prophylaxis, is frequently used off-label for the management of persistent post-traumatic headaches following concussion. Its dual mechanism involving both serotonin and norepinephrine reuptake inhibition and anticholinergic effects makes it a useful agent for patients who present with the combination of headache, sleep disturbance, and mood symptoms, as low doses, typically 10 to 25 milligrams at bedtime, can simultaneously address multiple symptom domains. Amitriptyline's sedating properties are advantageous when taken at bedtime, as they can promote sleep initiation in patients with concurrent insomnia, though this same property may contribute to morning drowsiness that interferes with daytime functioning and rehabilitation participation. Other tricyclic antidepressants, including nortriptyline, may offer similar headache prophylactic benefits with a somewhat more favorable side effect profile regarding sedation and anticholinergic effects. Beta blockers, particularly propranolol, represent another prophylactic option for patients with post-traumatic headache of migraine phenotype, though their use requires careful consideration in athletes and physically active individuals due to potential effects on exercise capacity and heart rate. Topiramate has also been used for post-traumatic headache prophylaxis, though its cognitive side effects, including word-finding difficulty, decreased processing speed, and impaired concentration, are particularly problematic in the post-concussion population, where cognitive symptoms may already be present. The selection of a headache prophylactic agent should be guided by the patient's complete symptom profile, with the goal of choosing an agent whose side effect profile is either neutral or beneficial with respect to the patient's other symptoms. Post-traumatic headaches warrant a comprehensive management approach that integrates pharmacological and non-pharmacological strategies. Post-traumatic headaches represent the most common and frequently the most debilitating persistent symptom following concussion, affecting approximately 70 to 90% of patients in the acute phase and persisting in 30 to 50% of patients at 3 months post-injury. Post-traumatic headaches most frequently present with features of migraine headache, followed by tension-type headache, and may also demonstrate features of cervicogenic headache, a distinction that has important implications for treatment selection. The pathophysiology of post-traumatic headache is multifactorial, involving neuroinflammatory processes, altered central pain modulation, cervical spine dysfunction, and psychological factors including anxiety and catastrophizing about headache symptoms. A comprehensive approach to post-traumatic headache management integrates pharmacological and non-pharmacological strategies, with treatment selection guided by the predominant headache phenotype. For headaches with migraine features, acute treatment may include triptans, non-steroidal anti-inflammatory drugs, or combination analgesics, while prophylactic options include amitriptyline, beta blockers, and topiramate, as discussed previously. For headaches with tension-type features, acetaminophen and non-steroidal anti-inflammatory drugs may provide acute relief, while physical therapy addressing cervical myofascial trigger points, postural dysfunction, and temporomandibular joint involvement may reduce headache frequency and severity. Cervicogenic headache responds best to cervical spine manual therapy, including joint mobilization, soft tissue mobilization, and specific strengthening exercises for the deep cervical flexor musculature. Medication overuse headache represents an important and frequently underrecognized complication in patients with persistent post-traumatic headache. Regular use of acute headache medications, including over-the-counter analgesics, triptans, and combination products, on more than 10 to 15 days per month can paradoxically perpetuate and worsen the headache disorder. Clinicians should screen for medication overuse in all patients with persistent headache and provide education about the risks of frequent analgesic use. A 12-month follow-up study showed that over-the-counter medications provided complete relief in only 26% of cases with migraine phenotype, and only 8% of patients were treated with triptans, suggesting both significant undertreatment with appropriate agents and potential over-reliance on less effective over-the-counter medications. A systematic clinical decision framework ensures appropriate patient selection, informed consent, and structured monitoring when pharmacological treatment is initiated. The overarching principle is that pharmacological interventions should generally be reserved for patients whose symptoms persist beyond the expected recovery window, typically 4 weeks or longer, and who have not responded adequately to first-line non-pharmacological interventions, including psychoeducation, activity modification, and targeted rehabilitation. This sequencing ensures that the natural recovery process is given adequate time and that patients are not unnecessarily exposed to medication side effects during a period when spontaneous improvement is expected. When pharmacological treatment is indicated, the selection of agents should be guided by the patient's predominant symptom domain, the side effect profile of available agents in relation to the patient's complete symptom picture, and the patient's concurrent medications and medical comorbidities. For patients with predominant cognitive dysfunction, methylphenidate or guanfacine should be considered as first-line agents. For patients with predominant mood disturbance, sertraline or another SSRI is recommended. For patients with predominant headache, the choice between triptans for acute management and prophylactic agents, such as amitriptyline or propranolol, should be guided by headache frequency, severity, and phenotype. For patients with prominent sleep disturbance, melatonin or low-dose amitriptyline may address both sleep and comorbid symptoms. Monitoring protocols should include scheduled follow-up assessments at 2 to 4 week intervals following medication initiation, with systematic evaluation of both target symptom improvement and adverse effects. Patients should be educated about expected timelines for therapeutic benefit, typically 2 to 4 weeks for most agents, and the importance of reporting side effects promptly. Medication trials that do not produce meaningful improvement within 6 to 8 weeks should be reassessed, with consideration given to dose adjustment, medication switching, or augmentation with complementary non-pharmacological approaches. The goal of pharmacological management is always to support and facilitate the patient's engagement in active rehabilitation, not to replace it. Emerging therapies for post-concussion recovery are an area of active investigation, with preliminary research examining neuromodulation techniques, novel pharmacological targets, and combination approaches that integrate pharmacological and non-pharmacological strategies. However, the current evidence base for these emerging approaches remains limited, and they should be considered experimental until supported by adequately powered randomized controlled trials. Module 5 addresses the Graduated Return to Sport Protocol, which has become the international standard for guiding athletes safely back to full participation following concussion. The return to sport process is structured as a stepwise, graduated protocol endorsed by the Amsterdam Consensus Statement, the American Academy of Pediatrics Council on Sports Medicine and Fitness, and multiple international sporting bodies. The 6-stage graduated return to sport program provides a systematic framework for progressive loading of the cardiovascular, cognitive, and musculoskeletal systems while monitoring for symptom recurrence. The protocol begins with symptom-limited daily activities in Stage 1, which athletes may initiate within 24 hours of injury. Stage 2 introduces light aerobic exercise, such as walking or stationary cycling at a slow to medium pace without resistance training, with the goal of increasing heart rate. Stage 3 incorporates sport-specific exercise, including running or skating drills, but explicitly excludes activities involving risk of head impact. Stage 4 advances to non-contact training drills with harder team-based exercises and the introduction of progressive resistance training. Stage 5 involves full contact practice following medical clearance, and Stage 6 represents unrestricted return to sport with normal gameplay. Each stage requires a minimum of 24 hours, and only one stage should be completed per day. Progression is contingent on the athlete's symptom response. Mild and brief exacerbations of concussion symptoms are defined as no more than a 2-point increase on a 0 to 10 symptom severity scale compared with pre-exercise baseline that resolves within 1 hour. Symptom exacerbations exceeding these thresholds should prompt a return to the previous stage and a minimum 24-hour pause before reattempting progression. If symptoms persist or worsen, reevaluation by a healthcare provider is indicated. A thorough understanding of each stage within the graduated protocol is essential for clinicians who guide athletes through the recovery process. Stage 1, symptom-limited daily activities, begins within 24 hours of injury and represents the transition from the brief relative rest period to active engagement in daily life. During this stage, patients are encouraged to resume normal activities of daily living, including light housework, short walks, and brief periods of social interaction, while avoiding activities that provoke more than mild symptom exacerbation. The purpose of Stage 1 is to reintroduce physical and cognitive demands at a minimal level while monitoring the patient's symptom response to establish the baseline from which progression will occur. Stage 2, light aerobic exercise, introduces structured cardiovascular activities such as walking, swimming, or stationary cycling at an intensity that elevates the heart rate to approximately 55% of estimated maximum. The duration of exercise at this stage typically ranges from 15 to 20 minutes, and the activity should not include any resistance training or sport-specific movements. Stage 3, sport-specific exercise, advances the complexity of activity to include running drills, skating drills, or other sport-specific movements that do not involve contact or collision risk. Importantly, the transition from Stage 2 to Stage 3 should only occur after the athlete has fully returned to school or other cognitive activities, as this sequencing reflects the principle that cognitive recovery should precede the demands of sport-specific physical activity. Stages 4 through 6 represent the final phases of the return to sport continuum. Stage 4 introduces non-contact training drills of increasing complexity, including tactical exercises and progressive resistance training within the context of team practices. Stage 5 requires medical clearance from a qualified healthcare provider before the athlete may participate in full contact practice, marking the final evaluation point before unrestricted sport participation. Stage 6 represents the return to normal gameplay without restrictions. At each stage, the monitoring criteria remain consistent. Symptom exacerbations should not exceed a 2-point increase on the 0 to 10 scale and should resolve within 1 hour, and any failure to meet these criteria should prompt a return to the previous stage with a 24-hour rest period before reattempting progression. The aerobic component of the return to sport protocol follows a physiologically based approach modeled after cardiac rehabilitation, with heart rate guiding exercise intensity. The heart rate at the patient's threshold for more than mild symptom exacerbation on exercise testing is used to prescribe aerobic exercise intensity, with light activity prescribed at no more than 55% of estimated maximum heart rate and moderate activity at no more than 70%, using the formula 220 minus the patient's age. This individualized, heart rate-guided approach addresses a fundamental limitation of earlier protocols that required complete symptom resolution before any return to activity, a criterion that failed to account for baseline symptoms such as fatigue and sleep problems that may be pre-existing, concussion-related, or both. Athletes should not advance beyond Stage 2, light aerobic exercise, until they have returned to their pre-injury symptom levels and are fully participating in school or other cognitive activities. This sequencing reflects evidence that cognitive and physical recovery proceed along parallel but distinct timelines, and that premature advancement to higher intensity physical activities while cognitive symptoms remain elevated may prolong overall recovery. Meta-analysis of recovery timelines demonstrates that the mean time to symptom-free status is 14 days, the mean time to full return to school is 8.3 days, and the mean time to unrestricted return to sport is 19.8 days, though there is substantial individual variability. Adolescents aged 13 to 17 years demonstrate significantly longer recovery trajectories compared to both younger children and college-aged athletes, necessitating a more conservative management approach. In a retrospective cohort study, adolescents aged 13 to 17 were symptom-free at a median of 14 days compared to 12 days for children aged 8 to 12, and required a median of 19.5 days to return to play compared to 14 days in younger children. Adolescents report more difficulty with school than younger children or adults, particularly with regard to greater initial symptom burden and specific symptoms such as difficulty concentrating, headaches, dizziness, and fatigue. Approximately 30% of pediatric and adolescent athletes take 1 month or longer to recover from sport-related concussion, a substantially longer period than the earlier estimate of 7 to 10 days that dominated clinical thinking for many years. The American Academy of Neurology guidelines specifically recommend that clinicians supervising athletes of high school age or younger should manage them more conservatively regarding return to play than older athletes, reflecting the probable risk factor of younger age and level of play for prolonged recovery. Among collegiate athletes in the NCAA DoD Care Consortium, median time to initiate the return to play protocol was 6.4 days, with median total return to play duration of 12.8 days. However, it was not until 1 month post-injury that 92% of athletes were cleared to begin the protocol, or 85% were cleared for unrestricted participation. Emerging evidence reveals substantial sport-specific variation in recovery trajectories and adverse outcome rates, even when graduated protocols are uniformly applied. Football participation significantly increases both normalized missed games and days missed after head injury in multivariable analysis controlling for sex, age, concussion history, learning disability, and attention deficit/hyperactivity disorder. Ice hockey was associated with significantly more days missed after head injury compared to football, with a mean difference of 5.4 days. Wrestling demonstrated the longest median recovery times across all measured parameters among collegiate athletes, with 8.6 days to asymptomatic status, 6.3 days for return to play protocol duration, and 16.9 total days to return to play. Athletes participating in individual sports have longer return to play times compared with those in team sports, with this factor achieving the largest effect on recovery times in multivariable analysis. Among female high school athletes, girls soccer carries the highest concussion risk at 0.30 to 0.73 per 1,000 athletic exposures, and female athletes consistently demonstrate longer recovery trajectories than males across all age groups. These sport-specific patterns persist despite adherence to standardized graduated protocols, suggesting that current guidelines may benefit from sport-specific modifications that account for the unique biomechanical, physiological, and cultural factors associated with different athletic disciplines. The management of athletes with a history of multiple concussions requires heightened clinical vigilance and a more conservative approach. Epidemiological evidence consistently demonstrates that a history of prior concussion is the strongest predictor of future concussion, with athletes who have sustained one previous concussion being approximately 2 to 3 times more likely to sustain a subsequent concussion compared to those with no concussion history. Furthermore, each successive concussion tends to be associated with lower impact thresholds, greater symptom severity, and longer recovery times, suggesting a cumulative vulnerability that has important implications for long-term neurological health. The concept of second impact syndrome, a rare but potentially fatal condition in which a second concussive event occurs before the brain has fully recovered from the first, underscores the critical importance of ensuring complete physiological recovery before return to contact or collision sport. While the existence and precise pathophysiology of second impact syndrome remain debated in the medical literature, the clinical imperative is clear. Athletes should not be exposed to the risk of a second head impact until they have demonstrated complete symptom resolution, normalization of cognitive and balance function, and successful completion of the graduated return to sport protocol without setbacks. For athletes with a history of 3 or more concussions, or those who demonstrate a pattern of increasingly severe or prolonged symptoms with successive injuries, a candid discussion about the potential risks of continued sport participation may be warranted, particularly in youth and adolescent populations. Several specific risk factors for prolonged recovery and premature return to play have been identified that directly inform clinical decision-making. History of prior concussion emerges as the most predictive factor for prolonged return to play times in multivariable analysis, with athletes who have sustained previous concussions demonstrating a higher risk of subsequent concussion and greater severity and duration of symptoms. 6 specific acute symptoms are significantly correlated with prolonged return to play: balance problems, difficulty concentrating, light sensitivity, drowsiness, fatigue or low energy, and difficulty remembering, with the total number and severity of symptoms being additive in a dose-dependent fashion. Pre-existing conditions, including mood disorders, learning disorders, attention deficit disorders, and migraine headaches, further complicate diagnosis and management and are associated with prolonged recovery. The prohibition against same-day return to play is a fundamental safety principle endorsed by all major consensus groups. Despite this consensus and the existence of state laws mandating removal from play, literature reveals that 10 to 38% of young athletes reported returning to play on the same day as their injury. Athletes who continued to play immediately after concussion were 8.8 times more likely to have a recovery longer than 21 days, and those who sustained an additional head impact within 24 hours of the first had greater symptom burden and longer recovery time, at 52.3 versus 36.9 days. The odds of immediate removal from play were higher when an athletic trainer performed the initial evaluation, with an odds ratio of 2.8, and the odds of prolonged return to sport beyond 21 days were lower for those with an athletic trainer present, with an odds ratio of 0.74. Medical clearance for unrestricted return to sport represents a pivotal clinical decision that carries significant implications for patient safety. The Amsterdam Consensus Statement recommends that medical clearance should be based on the convergence of multiple clinical indicators rather than any single criterion. These indicators include the resolution of concussion-specific symptoms to pre-injury levels, normalization of cognitive function as assessed by standardized neurocognitive testing, restoration of normal balance and vestibulo-ocular function, demonstration of normal exercise tolerance on graded exercise testing without symptom exacerbation, and successful completion of all stages of the graduated return to sport protocol without setbacks. The qualified healthcare provider responsible for return-to-play clearance should possess expertise in concussion management and should ideally have access to the complete clinical record, including pre-injury baseline assessments when available. The clearance decision should not be delegated to coaches, parents, or the athletes themselves, as research demonstrates that athletes frequently underreport symptoms in an effort to expedite their return to competition. Among high school athletes, studies have documented that up to 50% of athletes with concussion do not report their symptoms to coaches or medical staff, highlighting the importance of objective clinical assessment in the clearance process. For adolescent athletes, a more conservative approach to clearance is warranted, given their longer recovery trajectories and the potential consequences of premature return. The American Academy of Neurology guidelines specifically state that clinicians supervising athletes of high school age or younger should manage them more conservatively regarding return to play than older athletes, and the American Academy of Pediatrics recommends that no same-day return to play be permitted for any athlete under 18 years of age, regardless of how quickly symptoms appear to resolve. Athletes with a history of multiple concussions, those who required prolonged recovery from previous concussions, or those with risk factors for prolonged recovery should receive particularly careful assessment before clearance, as these individuals may be at increased risk for subsequent concussion and adverse outcomes. Emerging evidence has consistently demonstrated significant sex-based differences in concussion incidence, symptom presentation, and recovery trajectories. In sex-comparable sports including soccer, basketball, and baseball softball, female athletes sustain concussions at rates 1.5 to 2.0 times higher than their male counterparts, with girls soccer carrying the highest concussion risk among female high school sports at 0.30 to 0.73 per 1,000 athletic exposures. Female athletes also tend to report greater initial symptom burden, with higher scores on symptom checklists and a greater prevalence of symptoms including headache, dizziness, fatigue, and emotional disturbance compared to male athletes with comparable injury mechanisms. Recovery trajectories differ by sex, with female athletes consistently demonstrating longer time to symptom resolution and return to sport across all age groups. A longitudinal study examining patterns of post-concussive symptoms across the lifespan found that females report higher symptom loads than males at both acute and follow-up time points, and that specific symptom clusters, particularly somatic symptoms including headache and fatigue, are more persistent in female patients. These sex-based differences may reflect a combination of biological factors including hormonal influences on neuroinflammatory responses, differences in neck musculature, and head-neck biomechanics that result in greater brain acceleration for a given impact force, and psychosocial factors including differential symptom reporting patterns and healthcare-seeking behaviors. From a clinical management perspective, these findings underscore the importance of sex-sensitive concussion care that acknowledges and accounts for these differences in assessment, treatment planning, and return-to-activity decision-making. Clinicians should be aware that female athletes may require longer recovery periods and may benefit from earlier referral to multidisciplinary services, particularly for headache management, vestibular rehabilitation, and psychological support. The hormonal influences on concussion recovery remain an active area of investigation, with preliminary evidence suggesting that the phase of the menstrual cycle at the time of injury may influence symptom presentation and recovery trajectory, though this research is still in its early stages and does not yet support specific clinical recommendations. Module 6 focuses on the return to school and return to work processes, beginning with the strategies that guide academic reintegration. Return to school is prioritized in the management of adolescent concussion, as prolonged absence from cognitive activities and social engagement may itself contribute to symptom persistence and delayed recovery. The evidence supports early, symptom-limited cognitive activity and reintegration into the academic environment, with meta-analysis demonstrating a mean time to full return to school of 8.3 days, with 93% of students achieving full return by 10 days post-injury. Critically, full return to sport should only occur after successful reintegration into school, particularly for activities involving risk of contact or collision, reflecting the principle that cognitive recovery typically precedes the physiological readiness required for unrestricted athletic participation. Academic accommodations are a cornerstone of the return-to-school process and should be individualized based on the student's symptom profile and academic demands. Recommended accommodations include modified attendance schedules, breaks from cognitive tasks, limited screen time, extra time for assignments and examinations, and reduced workload expectations during the acute recovery period. A prospective cohort study of 1,715 collegiate athletes found that athletes initiating full academics while still symptomatic were 21.5% less likely to return to full sport within 14 days, and 19.1% more likely to experience prolonged return beyond 28 days, underscoring the importance of appropriate academic pacing during recovery. In many jurisdictions, students recovering from concussion are entitled to formal academic accommodations under disability and education law. In the United States, concussion may qualify students for accommodations under Section 504 of the Rehabilitation Act, or, in cases of prolonged disability, under the Individuals with Disabilities Education Act, known as IDEA. These legal frameworks require schools to develop individualized accommodation plans that address the student's specific functional limitations and are reviewed and updated as the student's condition changes. Healthcare providers play a critical role in documenting the medical necessity for academic accommodations and in providing schools with specific, actionable recommendations that can be translated into a formal accommodation plan. Return-to-work protocols for adults must be individualized based on occupational demands, with strategies differing substantially between physically demanding and cognitively demanding roles. A systematic review examining interventions to help adults with concussion return to work identified that effective approaches include psychotherapy, neuropsychological training, vestibular rehabilitation, vision rehabilitation, exercise, compensatory strategies, cognitive training, vocational support, and interpersonal training. The most promising behavior change techniques for facilitating return to work include providing instruction on how to perform required tasks, reducing negative emotions, action planning, providing information about health consequences, and encouraging problem solving. Workers with mild traumatic brain injury frequently take 1 month or longer to return to work, and unemployment at 3 months may be as high as 1/3 of patients. When returning to work, patients consistently report that they expend greater effort and become more fatigued relative to pre-injury levels. Among workers who do return, only about 1/3 work under similar conditions as before injury, with weekly working hours decreasing substantially in some populations. These findings underscore the need for graduated, accommodated return-to-work protocols rather than abrupt transitions back to full occupational duties. For workers in physically demanding roles, the return-to-work process closely parallels the graduated return-to-sport protocol. Early assessment should include evaluation of exertional tolerance using graded exercise testing or symptom-limited activity protocols to establish safe thresholds for physical work tasks. Specific workplace modifications include gradual increase in physical workload starting with light-duty tasks and progressing to full-duty activities, task-specific modifications such as reducing lifting requirements or avoiding overhead work, activity pacing, and rest breaks to prevent symptom exacerbation during prolonged physical exertion, monitoring of exertional tolerance using heart rate targets or symptom thresholds, and delayed return to high-risk tasks involving potential for re-injury, such as work at heights or operating heavy machinery. Workers in physically demanding roles frequently take longer to return to full-duty work, with some requiring 1 month or more, and may experience greater effort and fatigue relative to pre-injury levels. Vestibular rehabilitation and vision therapy are particularly important for workers whose jobs involve balance, coordination, or visual tracking, and targeted physical therapy may be needed to address specific job-related tasks such as lifting, carrying, or prolonged standing through progressive loading and task-specific training. For workers in sedentary, cognitively demanding roles, the return-to-work process must address unique challenges posed by sustained attention, complex problem-solving, multitasking, and prolonged screen time. Workers in these roles, including healthcare workers, educators, information technology professionals, and management or executive personnel, may find that even tasks they previously performed automatically now require deliberate effort and concentration. Cognitive deficits affecting attention, processing speed, and memory are frequently present during the first week to month after concussion. Workplace accommodations for cognitive workload include limited screen time with frequent breaks, reduced multitasking and complex problem-solving demands, flexible work hours or part-time schedules, environmental modifications such as reducing noise and visual distractions, and cognitive accommodations including written instructions, checklists, or assistive technologies to support attention and memory. Compensatory strategy training, including environmental modifications to facilitate attention and establishing new techniques for organization and note-taking, supports daily functioning and work activities, though successful long-term utilization requires specialized evaluation and sufficient practice in meaningful real-life contexts. Physical therapists, occupational therapists, and nurses each contribute essential and complementary expertise to the return-to-work process. Physical therapists assess and address the physical demands of the worker's occupation, conducting functional capacity evaluations that measure the worker's ability to perform job-specific tasks, including lifting, carrying, standing, climbing, and overhead reaching. For workers in physically demanding roles, physical therapists design graduated work conditioning programs that progressively increase physical demands to match the requirements of the worker's position while monitoring exertional tolerance and symptom response. They also provide targeted intervention for cervical, vestibular, and balance impairments that may limit the worker's ability to perform safely in environments requiring coordination, spatial awareness, or work at heights. Occupational therapists bring specialized skills in cognitive and functional assessment that are particularly valuable for workers returning to sedentary, cognitively demanding roles. They conduct comprehensive evaluations of the worker's cognitive capacities, including attention, memory, processing speed, executive function, and multitasking ability, and relate these findings directly to the specific cognitive demands of the worker's job tasks. Occupational therapists then design compensatory strategy programs that enable the worker to manage cognitive limitations while maintaining productivity, including the use of organizational tools, environmental modifications, task simplification strategies, and structured scheduling approaches. Their expertise in worksite assessment allows them to recommend specific environmental modifications, such as noise reduction, optimized lighting, ergonomic adjustments, and reduced visual clutter that support the worker's cognitive functioning in the workplace setting. Nurses contribute to the return-to-work process through case management, employer communication, medication management, and ongoing monitoring of the worker's health status during the transition back to employment. Occupational health nurses, in particular, serve as liaisons between the treating healthcare team and the employer, translating clinical recommendations into practical workplace accommodations and monitoring the worker's adjustment to increasing work demands. Nurses also screen for the development of secondary conditions that may emerge during the return-to-work transition, including anxiety, depression, and stress-related symptoms, ensuring that these are addressed promptly before they become barriers to sustained employment. Registry data and emerging research reveal important occupation-specific considerations that influence recovery and return to work following concussion. Individuals aged 30 to 39 years, those with high income and wage earners with management experience, had markedly lower incidence of favorable labor market transitions, with hazard ratios ranging from 0.60 to 0.83, and higher incidence of adverse transitions, with a hazard ratio of 1.46 compared to controls. Employees with persistent post-concussion symptoms report difficulties with work tasks 43% of the time, struggling particularly with multitasking and work speed. These findings suggest that workers in cognitively demanding professional roles may experience more prolonged work disability than the general population with mild traumatic brain injury. A cost-effectiveness analysis of combined compensatory cognitive training with supported employment versus treatment as usual in patients with mild to moderate traumatic brain injury found a significantly higher proportion of participants in the combined intervention group had returned to work at 3 months, with the intervention being cost-effective from a societal perspective, as costs related to productivity loss accounted for 84% of total costs and were lower in the intervention group. This evidence supports the integration of cognitive rehabilitation with vocational support as a comprehensive approach to facilitating return to work, particularly for workers with persistent cognitive symptoms. Supportive elements identified across occupation types include individualized rehabilitation services, graduated return-to-work protocols, workplace accommodations, social support from colleagues and supervisors, and developing personal agency in the individual recovering from concussion. Challenges include lack of patient education about concussion and expected recovery, delayed access to rehabilitation services, and inadequate workplace accommodations that fail to match the worker's symptom profile and functional limitations. Addressing these barriers requires widespread concussion and return-to-work education and training for healthcare providers, employers, and workers themselves, as well as standardized recovery guidelines and accessible mental health supports. Analogous to the graduated return-to-sport protocol, a structured stepwise return-to-learn protocol provides a systematic framework for reintegrating students into full academic participation. The return-to-learn protocol typically progresses through 5 stages, each of which requires a minimum of 24 hours and is contingent on the student's symptom response. Stage 1 involves daily activities at home that do not provoke symptoms, including light reading, drawing, or watching short segments of television. Stage 2 introduces homework activities, beginning with reduced workload and gradually increasing the volume and complexity of academic tasks. Stage 3 involves a partial return to school, with modifications such as a reduced schedule, frequent breaks, and quiet spaces for rest when symptoms flare. Stage 4 represents a gradual return to full school attendance, with continued accommodations such as extra time for assignments and reduced testing demands. Stage 5 marks the resumption of normal academic activities without accommodations. Symptom monitoring during the return-to-learn process should incorporate both student self-report and teacher observations, as students may not always accurately assess their own cognitive limitations. Teachers should be educated about the subtle signs of cognitive fatigue in concussed students, including decreased attention span, increased errors on assignments, social withdrawal, irritability, and complaints of headache or visual discomfort that worsen during sustained cognitive tasks. The occupational therapy role in the return-to-learn process is particularly valuable, as occupational therapists can conduct classroom observations, identify environmental barriers to participation, recommend specific modifications to the physical and sensory environment, and provide direct intervention for visual, perceptual, and executive function deficits that interfere with academic performance. Emerging evidence supports the concept of cognitive rest prescriptions that are individualized to the student's symptom profile, rather than applying a one-size-fits-all approach to academic modification. For example, a student whose primary symptoms are visual, such as light sensitivity and convergence insufficiency, may require modifications focused on reducing screen time and reading demands, while a student with predominant attention and memory difficulties may benefit from reduced class load and extended testing time. Individualized accommodation plans developed collaboratively by healthcare providers, school personnel, and families optimize the balance between cognitive rest and the educational engagement that is essential for the student's academic progress and psychosocial well-being. The return-to-work process requires ongoing monitoring, dynamic adjustment of accommodations, and effective employer education. Regular follow-up assessments, typically at 1 to 2 week intervals during the active return-to-work phase, should evaluate the worker's symptom response to increasing occupational demands, their subjective assessment of work performance and effort, and any new or emerging symptoms that may require clinical attention. The goal is to progressively advance accommodations toward full-duty responsibilities as the worker demonstrates sustained tolerance at each level of demand. Workers who experience setbacks defined as a return of symptoms to levels that interfere with work performance should be stepped back to the previous accommodation level rather than removed from work entirely, maintaining the therapeutic benefits of occupational engagement while respecting the worker's symptom limitations. Effective return to work following concussion requires not only clinical management but also education and engagement of employers, supervisors, and human resources personnel. Many employers have limited understanding of concussion, its functional consequences, and the rationale for graduated protocols, which can result in inappropriate expectations, inadequate accommodations, or premature return to full-duty responsibilities. Workplace accommodation letters should specify concrete, measurable modifications rather than vague restrictions. For example, rather than stating that the worker requires reduced cognitive demands, the accommodation letter might specify a maximum of 4 hours of screen-based work per day, a 15-minute break from cognitive tasks every 90 minutes, temporary reassignment from multitasking roles to sequential single-task responsibilities, and a quiet workspace with reduced auditory and visual stimulation. These specific recommendations enable employers to make practical workplace adjustments and provide a clear framework for monitoring progress. Organizational culture plays a significant role in shaping the return-to-work experience. Qualitative research has identified several workplace culture factors that influence outcomes, including the degree of understanding and support from supervisors and colleagues, the availability of flexible work arrangements, and the extent to which the worker feels empowered to communicate their limitations without fear of professional consequences. Workers who perceived their workplace as supportive and accommodating reported better adherence to return-to-work recommendations and greater confidence in their recovery trajectory, while those who faced skepticism, pressure to return to full duties prematurely, or lack of understanding from supervisors, reported higher levels of anxiety, frustration, and delayed recovery. Module 7 examines the objective assessment tools that guide return-to-activity decisions, beginning with graded exercise testing using the Buffalo Concussion Treadmill Test. Graded exercise testing, particularly the Buffalo Concussion Treadmill Test, or BCTT, represents the most established objective measure for assessing physiological recovery and guiding return-to-activity decisions following concussion. Exercise intolerance is recognized as an objective physiological sign of acute concussion that reflects impaired autonomic function and cerebral blood flow autoregulation. The BCTT systematically assesses exercise tolerance by measuring the heart rate at which patients experience more than mild symptom exacerbation, defined as an increase of more than 2 points on a 0 to 10 symptom severity scale. This heart rate threshold can then be used to prescribe individualized aerobic exercise rehabilitation programs in an approach modeled after cardiac rehabilitation. Lower baseline exercise tolerance has significant prognostic implications. Research examining the relationship between exercise tolerance and recovery outcomes in adults with persistent post-concussion symptoms found that lower baseline delta heart rate and heart rate thresholds significantly correlated with less symptom improvement in adults receiving standard care. This suggests that patients with lower exercise tolerance at baseline may require more intensive, customized rehabilitation rather than standard symptom-based management. Early symptom-limited graded exercise testing appears to be safe in adults and can be performed as early as 24 to 72 hours post-injury to guide activity prescription and establish baseline physiological parameters. Validated symptom scales and neuropsychological testing each play important but distinct roles in monitoring concussion recovery. Validated symptom scales remain the cornerstone of concussion recovery monitoring, providing standardized quantitative data that enables tracking of symptom trajectories over time. The VA-DoD Clinical Practice Guideline identifies the Neurobehavioral Symptom Inventory and the Rivermead Post-Concussion Questionnaire as critical outcome measures for assessing symptom improvement, alongside exertional test improvement for return-to-activity decisions. The SCOAT6, as discussed in Module 1, provides the most comprehensive single-instrument assessment available, evaluating symptoms across cognitive, physical, vestibulo-ocular, autonomic, sleep, and mental health domains within a serial monitoring framework. These scales enable comprehensive, multimodal evaluation across disciplines and support the serial monitoring that is essential for evidence-based decision-making. Functional and activity-based milestones are used to define successful return to activity, with mean time to symptom resolution approximately 14 days, mean time to full return to school about 8 days, and mean time to unrestricted return to sport around 20 days, though there is substantial individual variability. Regarding neuropsychological testing, the evidence indicates that routine comprehensive testing is not recommended in the post-acute period within the first 30 days for all patients, as cognitive deficits affecting memory, complex attention, working memory, and processing speed typically resolve within days to weeks. There is no clear correlation between self-reported cognitive symptoms and formal testing findings beyond the initial 7 to 30 days. Automated screening tools such as the Automated Neuropsychological Assessment Metrics, the Neurocognitive Assessment Tool, and the Immediate Post-Concussion Assessment and Cognitive Testing, known as IMPACT, are not recommended for routine use in patients presenting with symptoms in the post-acute period. However, comprehensive neuropsychological testing may be valuable at specific points in care for patients with persistent cognitive symptoms, particularly those attempting to return to cognitively demanding occupations. The VA-DoD guidelines recommend that short-term trials of evidence-based cognitive rehabilitation spanning 4 to 6 sessions may provide sufficient information to determine whether a patient is likely to benefit from further cognitive rehabilitation, serving as both a therapeutic intervention and a diagnostic tool. Effective concussion management requires structured, interdisciplinary collaboration that addresses the physical, cognitive, emotional, and social dimensions of recovery. When effectively organized, interdisciplinary care represents a powerful facilitator of recovery, with regular case conferences, shared care plans, and clear delineation of roles ensuring that all relevant domains are comprehensively addressed. A scoping review of occupational and physiotherapy modalities used to support interdisciplinary rehabilitation after concussion confirmed the value of coordinated multimodal approaches that integrate the distinct but complementary expertise of physical therapists, occupational therapists, speech-language pathologists, psychologists, and physicians. Technology-enhanced care pathways represent an emerging model for facilitating interdisciplinary communication and preventing stagnation in care. The Cleveland Clinic Concussion Application, known as C3, provides a structured framework for interdisciplinary communication, ensuring timely referral to appropriate providers based on patient progress through defined clinical milestones. Such technology-enhanced approaches may help address the common barriers of role ambiguity and fragmented care that impede effective multidisciplinary collaboration, particularly for inexperienced clinicians who may struggle to navigate the complexities of concussion management without robust mentorship or structured protocols. Interprofessional collaborative management of post-concussion cognitive symptoms has been described as a model that brings together physical therapists, occupational therapists, speech-language pathologists, and neuropsychologists to address the overlapping cognitive, communication, and functional deficits that commonly persist following concussion. This model emphasizes shared assessment, coordinated goal setting, and ongoing communication among team members, with each discipline contributing its unique perspective to the development of individualized treatment plans that reflect the patient's functional priorities. Effective interdisciplinary collaboration requires clear role delineation and structured communication frameworks. Physical therapists, occupational therapists, and speech-language pathologists may all address aspects of cognitive function, balance, and visual processing, and without explicit role clarification, care may become duplicated, contradictory, or fragmented. Structured communication frameworks such as regular team huddles, shared electronic documentation, and standardized handoff protocols provide the infrastructure necessary for coordinated care delivery. The Interdisciplinary Team Conference represents a best practice model for complex concussion cases, bringing together all treating providers to review the patient's current status, reconcile assessment findings across disciplines, identify areas of progress and stagnation, and collaboratively develop or revise the treatment plan. These conferences are particularly valuable when the patient is not progressing as expected, when there are discrepancies between symptom reports and objective findings, or when the patient is transitioning between phases of care, such as moving from acute management to the return to activity phase. The involvement of the patient in goal-setting discussions through models, such as shared decision-making and motivational interviewing, enhances treatment adherence and ensures that rehabilitation goals align with the patient's values and functional priorities. The implementation of evidence-based concussion management in real-world settings is shaped by both barriers and facilitators that must be understood and addressed. A primary barrier is the limited quality and scope of evidence supporting many specific interventions, particularly for adults and for chronic or persistent symptoms. Most recommendations for non-pharmacological interventions, including graded exercise, vestibular rehabilitation, manual therapy, and psychological treatment, carry weak recommendations due to very low to low certainty of evidence, which can engender hesitancy among clinicians to adopt active, multidisciplinary protocols. Underutilization and inconsistent integration of allied health professionals into concussion management teams represents another significant barrier. Survey data indicate that while healthcare providers generally express confidence in diagnosing concussion, there is limited knowledge of and referral to allied health professionals for ongoing management, resulting in missed opportunities for comprehensive, interdisciplinary care. System-level barriers include limited access to specialized providers, variability in insurance coverage, and disparities in resources across healthcare settings, especially in rural or underserved areas. The need for ongoing education and training for non-specialist providers, as well as for patients, families, and employers, is emphasized as a critical but often unmet need. Facilitators of effective implementation include the adoption of standardized, evidence-informed assessment tools such as the SCOAT6 and SCAT6, which enable consistent evaluation across disciplines and support serial monitoring of recovery. Therapeutic alliance building, individualized education, and patient empowerment are also key facilitators, with practices such as motivational interviewing and goal attainment scaling promoting self-management and sustained engagement in the recovery process. Ongoing education and training for clinicians, delivered through structured professional development programs and informed by emerging evidence, are essential for sustaining best practices and ensuring that the growing evidence base for concussion management is translated into clinical care. Systematic outcome measurement is essential for evaluating program effectiveness and driving quality improvement in concussion management. Key outcome measures include time to symptom resolution, time to return to full school or work participation, time to unrestricted return to sport, patient satisfaction with care, and functional outcomes at standardized follow-up intervals. The collection and analysis of these data at the program level enables identification of trends, benchmarking against published evidence, and targeted quality improvement initiatives that can enhance the efficiency and effectiveness of care delivery. Healthcare organizations with established concussion management programs should implement structured outcome tracking systems that capture these metrics for all patients managed through the program. Patient-reported outcome measures provide valuable data about the patient's subjective experience of recovery and their satisfaction with the care they have received. Validated instruments such as the Quality of Life After Brain Injury Scale, the Patient Health Questionnaire for Depression Screening, the Generalized Anxiety Disorder Scale, and the Pittsburgh Sleep Quality Index provide standardized assessments of domains that are important to patients but may not be captured by concussion-specific symptom scales alone. The integration of patient-reported outcomes into routine clinical practice supports patient-centered care and provides data that can inform both individual treatment decisions and program-level quality improvement. Advances in neuroimaging and blood-based biomarker research hold promise for improving the objectivity and precision of concussion assessment. Diffusion tensor imaging, functional magnetic resonance imaging, and magnetic resonance spectroscopy have demonstrated the ability to detect microstructural and functional changes following concussion that are not visible on conventional imaging, providing objective evidence of the pathophysiological changes underlying the clinical syndrome. These advanced imaging modalities have the potential to inform prognosis, guide treatment selection, and objectively document recovery, though their clinical utility is currently limited by cost, availability, lack of standardized protocols, and the absence of validated normative databases. Blood-based biomarkers represent another frontier in concussion assessment, with research examining the diagnostic and prognostic utility of several candidate markers, including glial fibrillary acidic protein, or GFAP, ubiquitin C-terminal hydrolase L1, or UCHL1, neurofilament light chain, or NFL, and tau protein. The FDA-cleared Banyan Brain Trauma Indicator, which measures GFAP and UCHL1 levels in blood, is approved for use in evaluating adults with suspected mild traumatic brain injury to assist in determining the need for CT imaging. However, its role in the broader assessment and management of concussion, including prognostication, monitoring recovery, and guiding return-to-activity decisions, remains under investigation. Neurofilament light chain has shown particular promise as a biomarker of axonal injury, with elevated levels observed following concussion that correlate with symptom severity and recovery duration in some studies. Wearable technology and sensor-based assessment tools represent an emerging area with significant potential for both research and clinical applications. Accelerometers and gyroscopes embedded in mouthguards, headbands, or helmets can quantify head impact biomechanics in real time, providing data on the magnitude, direction, and frequency of head impacts sustained during athletic participation. While these devices have limitations in accurately predicting clinical concussion from biomechanical data alone, they provide valuable information for understanding injury mechanisms and may eventually contribute to individualized risk assessment. Additionally, smartphone-based and tablet-based assessment platforms are increasingly available, offering standardized cognitive testing, balance assessment, and symptom monitoring capabilities that can be deployed at the point of care, in the home environment, or on the athletic sideline. Telehealth has emerged as an important modality for concussion management, particularly in rural and underserved areas where access to specialized care may be limited. Telehealth platforms enable remote symptom monitoring, clinical assessment, patient education, and interdisciplinary case conferences, reducing barriers related to geographic distance, transportation, and appointment availability. During the COVID-19 pandemic, the widespread adoption of telehealth demonstrated that many aspects of concussion management, including history taking, symptom assessment, psychoeducation, cognitive behavioral therapy, and clinical decision-making about return to activity progression, can be effectively delivered through virtual encounters. Physical therapists have adapted telehealth delivery to include guided home exercise programs, virtual vestibular rehabilitation sessions, and remote monitoring of exertional tolerance through heart rate tracking and symptom reporting. Occupational therapists have utilized telehealth to deliver cognitive rehabilitation, sleep hygiene interventions, and return-to-learn consultation, with some evidence suggesting that telehealth delivery may actually enhance engagement for adolescent patients who are more comfortable with technology-mediated communication. Nurses have leveraged telehealth for structured follow-up calls, medication management, and care coordination, ensuring continuity of care during the recovery period. While certain assessment components such as hands-on balance testing, cervical spine examination, and vestibular ocular motor screening are best performed in person, the integration of telehealth with periodic in-person evaluations offers a hybrid model that may optimize both access and quality of care. As we approach the conclusion of this course, let us integrate the key principles that should guide your concussion management practice across all rehabilitation disciplines. The management of concussion in adolescents and adults has evolved dramatically over the past decade, transitioning from a model of passive rest and symptom monitoring to an evidence-based paradigm of active rehabilitation, individualized assessment, and interdisciplinary collaboration. This course has examined the key pillars of contemporary concussion management: comprehensive multimodal assessment using the SCAT6 and SCOAT6, the paradigm shift from strict rest to early active recovery with subsymptom threshold aerobic exercise, targeted interventions for persistent post-concussion symptoms, including cervicovestibular rehabilitation, vestibular therapy, vision rehabilitation, cognitive behavioral therapy, and sleep interventions, judicious pharmacological management when non-pharmacological approaches are insufficient, structured graduated protocols for return to sport, school, and work, and the objective assessment tools and interdisciplinary collaboration models that underpin effective care delivery. Several overarching principles emerge from the evidence reviewed in this course that should guide clinical practice across all rehabilitation disciplines. First, the importance of individualized, patient-centered care cannot be overstated. Recovery from concussion is highly variable, and management plans must be tailored to the individual's specific symptom profile, functional goals, and psychosocial context rather than following a rigid one-size-fits-all protocol. Second, early intervention is consistently associated with better outcomes, whether in the form of early subsymptom threshold exercise, early referral to vestibular therapy, or early provision of psychoeducation and reassurance. Third, interdisciplinary collaboration is essential for addressing the multifaceted nature of concussion, and clinicians must actively seek to understand and leverage the complementary expertise of their colleagues across disciplines. For physical therapists, occupational therapists, and nurses, the evidence reviewed in this course underscores the vital and expanding role that each discipline plays in concussion management. Physical therapists bring irreplaceable expertise in musculoskeletal assessment, vestibular rehabilitation, exercise prescription, and return to sport progression. Occupational therapists contribute essential skills in functional assessment, cognitive rehabilitation, vision intervention, and the facilitation of meaningful activity engagement that is central to recovery. Nurses serve as critical care coordinators, patient educators, and mental health screeners who ensure that the broader biopsychosocial dimensions of recovery are addressed. When these disciplines work in concert, sharing assessment findings, coordinating treatment goals, and communicating effectively about patient progress, the result is comprehensive, evidence-based care that optimizes outcomes and supports the patient's safe return to the activities that matter most in their lives. Module 8 presents a comprehensive clinical case study that integrates the assessment, management, and return-to-activity principles from the preceding modules. This case follows an adolescent athlete through the full continuum of concussion care, highlighting interdisciplinary clinical reasoning and evidence-based decision-making. Mia is a 15-year-old female high school soccer player who sustained a concussion during a competitive match when she collided head-to-head with an opposing player while both were attempting to head the ball. She did not lose consciousness but appeared dazed on the field and was unable to recall the play that preceded the collision. The certified athletic trainer on the sideline removed Mia from play and administered the SCAT6 within 15 minutes of injury. Her initial SCAT6 scores revealed a post-concussion symptom scale score of 42 out of 132, with the most prominently endorsed symptoms being headache at severity, 5 out of 6, dizziness at 4 out of 6, difficulty concentrating at 4 out of 6, feeling mentally foggy at 4 out of 6, and sensitivity to light at 3 out of 6. Her standardized assessment of concussion score was 24 out of 30, reflecting errors in delayed recall and digit backward testing. Her modified balance error scoring system score was 8 errors, compared to a preseason baseline of 3 errors. Mia's medical history is significant for one prior concussion sustained 2 years earlier while playing recreational basketball, from which she recovered in approximately 10 days. She has a family history of migraine on her maternal side and a personal history of intermittent tension-type headaches occurring 1 to 2 times per month, managed with ibuprofen as needed. She denies any history of anxiety, depression, or learning disabilities. She is an honor student maintaining a 3.8 grade point average in a college preparatory curriculum. She reports sleeping approximately 7 hours per night on school nights, which she acknowledges is less than recommended. Mia presented to her primary care physician 48 hours post-injury, accompanied by her mother. She continued to report headache at severity 4 out of 6, dizziness with position changes, difficulty concentrating on homework, and light sensitivity. Her neurological screening examination was unremarkable, with no focal deficits, normal cranial nerve function, and intact strength, sensation, and reflexes bilaterally. No red flag symptoms were present, and neuroimaging was not indicated per the Canadian CT head rule. The physician administered the SCOAT6, which confirmed elevated symptom scores across the physical, cognitive, and sleep domains. Orthostatic vital sign testing revealed a heart rate increase of 22 beats per minute upon standing, from 68 supine to 90 standing, suggesting mild autonomic dysfunction. Based on the clinical presentation, including sport-related concussion with moderate initial symptom burden, prior concussion history, female sex, and pre-existing headache history, the physician identified Mia as having multiple risk factors for prolonged recovery. The physician prescribed a 48-hour period of relative rest with light daily activities and initiated the following management plan: avoidance of contact sports and vigorous physical activity, permission to engage in light walking at a comfortable pace, limited screen time with frequent breaks, modified academic schedule with reduced homework expectations, and return visit in 1 week for reassessment and initiation of subsymptom threshold aerobic exercise testing. Written and verbal education was provided to Mia and her mother regarding the nature of concussion, expected recovery timeline, red flag symptoms warranting emergency evaluation, and the importance of the graduated return to activity approach. The interdisciplinary management plan for Mia's concussion involved coordinated contributions from nursing, physical therapy, and occupational therapy over the first 5 weeks of recovery. The school nurse served as the primary liaison between the healthcare team and the school. Within 72 hours of the concussion diagnosis, the nurse coordinated with Mia's guidance counselor and teachers to implement a graduated return-to-learn protocol. Initial academic accommodations included a reduced class schedule with attendance at morning classes only for the first week, extra time for assignments and tests, permission to leave class for rest breaks when symptoms escalated, avoidance of standardized testing during the acute recovery period, and provision of a quiet room for break periods. The nurse conducted daily symptom checks during school hours, documenting Mia's self-reported symptom severity and her tolerance of cognitive activities. By day 7, the nurse noted that Mia was tolerating 4-hour school days with only mild headache exacerbation, prompting advancement to a 5-hour schedule with continued accommodations. The nurse also screened for emerging psychological symptoms at each check-in, recognizing that Mia expressed frustration about missing soccer matches and anxiety about falling behind academically. The nurse provided reassurance grounded in the evidence that the majority of adolescent concussions resolve within 2 to 4 weeks, normalized Mia's emotional response, and encouraged her to maintain social connections with teammates in a supportive capacity. The nurse communicated Mia's school-based progress to the primary care physician and the physical therapist through structured written updates, ensuring that the return-to-learn and return-to-sport progressions were coordinated. At 1 week post-injury, Mia was referred to physical therapy for exercise tolerance assessment and initiation of a supervised graduated return-to-activity program. The physical therapist conducted a comprehensive evaluation including the vestibular ocular motor screening, known as VOMS, cervical spine assessment, balance testing with dual task conditions, and a symptom-limited graded exercise test using a modified Buffalo concussion treadmill test protocol. VOMS testing revealed provocation of dizziness and headache with smooth pursuit at a symptom change of +2, horizontal SAC odds at +2, and near-point convergence measured at 12 centimeters above the normal threshold of 5 centimeters. Cervical spine assessment revealed increased tension in the upper trapezius and suboccipital musculature bilaterally, mild restriction of cervical rotation, and reproduction of Mia's typical headache with sustained cervical flexion. Balance testing demonstrated increased postural sway on foam surface with eyes closed compared to age-matched norms, with further degradation under dual task conditions when counting backward by 7s. The graded exercise test demonstrated that Mia reached a symptom exacerbation threshold with a headache increase of 3 points at a heart rate of 132 beats per minute, which corresponded to approximately 64% of her estimated maximum heart rate using the formula 220 minus 15 equals 205, and 64% equals 131 beats per minute. Based on these findings, the physical therapist prescribed daily aerobic exercise at a heart rate not exceeding 120 beats per minute, approximately 58% of estimated maximum, for 20 minutes, using stationary cycling or brisk walking. The physical therapist also initiated cervicovestibular rehabilitation, including cervical spine manual therapy with soft tissue mobilization to the suboccipital and upper trapezius regions and gentle cervical rotation mobilization, gaze stabilization exercises targeting the vestibulo-ocular reflex, smooth pursuit training, and convergence exercises. Occupational therapy consultation and the subsequent clinical outcomes illustrate the value of targeted, individualized intervention. Mia was referred to occupational therapy at day 10 when the school nurse reported that she was struggling with sustained reading, experiencing visual fatigue after 15 to 20 minutes of near-point visual work, and demonstrating declining homework completion despite accommodations. The occupational therapist conducted a functional visual assessment that confirmed convergence insufficiency consistent with the physical therapy findings, as well as reduced visual attention span and difficulty with visual scanning during reading tasks. Cognitive screening revealed mildly reduced processing speed and difficulty sustaining attention during complex academic tasks, lasting longer than 20 minutes. The occupational therapist developed a multi-component intervention plan that included visual hygiene education using the 20-20-20 rule, which means every 20 minutes looking at an object at least 20 feet away for at least 20 seconds. The plan also included structured activity pacing for homework with 10-minute breaks after every 20 minutes of near-point work, oculomotor exercises complementing the physical therapy convergence program, compensatory strategies for note-taking and assignment organization, including audio recording of lectures, use of graphic organizers, and chunking of complex assignments into smaller segments, and collaboration with teachers to modify assignment formats by reducing screen-based work, providing hard copies with enlarged font, and allowing oral rather than written responses where appropriate. By day 24, Mia reported that she could sustain 35 to 40 minutes of concentrated academic work before needing a break, and her homework completion rate had returned to approximately 85% of pre-injury levels. Mia attended physical therapy twice weekly for 4 weeks. By day 14, her exercise tolerance had improved to a symptom threshold of 152 beats per minute, or 74% of estimated maximum, and her VAMIS scores had normalized for smooth pursuit and horizontal saccades. Near-point convergence improved to 7 centimeters. By day 21, cervical symptoms had resolved with manual therapy and home exercise, and balance testing under dual-task conditions was within normal limits. The physical therapist cleared Mia to advance to Stage 3, sport-specific exercise, of the graduated return to sport protocol at day 21 and provided detailed written guidelines for progression through stages 3 through 5 with the athletic trainer. Mia's outcomes demonstrate the effectiveness of coordinated, evidence-based, interdisciplinary concussion management. Mia achieved full return to school without accommodations at day 18 and was progressing well through the graduated return to sport protocol. She completed Stage 3, sport-specific drills without contact, at day 23, Stage 4, non-contact team practice with progressive intensity, at day 26, and received medical clearance for Stage 5, full contact practice, at day 30 after demonstrating complete symptom resolution at pre-injury levels, normalization of all assessment measures including SCOAT6, VAMS, balance, and exercise tolerance, and successful completion of all return to sport stages without setback. She participated in 2 full contact practices without symptom recurrence and returned to competitive match play at day 33. Her total recovery time of approximately 5 weeks exceeded the typical 7 to 10-day timeline frequently cited for sport-related concussion, but was consistent with evidence that adolescent females with prior concussion history and pre-existing headache may require longer recovery periods. At 3-month follow-up, Mia reported no residual concussion symptoms, full return to her pre-injury academic performance, and successful participation in the remainder of the soccer season without further concussive events. The interdisciplinary team recommended that her pre-season baseline assessments be updated annually and that she continue the cervical strengthening program developed by her physical therapist as a potential protective factor against future concussion. This case illustrates several key principles addressed throughout this course. First, Mia's presentation highlights the importance of identifying risk factors for prolonged recovery at the initial evaluation. Her prior concussion history, female sex, pre-existing headache disorder, and elevated initial symptom burden each contributed independently to her extended recovery timeline. Second, the case demonstrates the value of early, coordinated interdisciplinary intervention, with physical therapy, occupational therapy, and nursing, each addressing distinct functional domains while communicating regularly to ensure that the return to learn and return to sport progressions were synchronized. Third, the identification and targeted treatment of cervicovestibular and oculomotor impairments through specific rehabilitation rather than passive waiting for symptom resolution likely contributed to Mia's recovery trajectory. Finally, the case underscores the importance of the school nurse as a care coordinator in adolescent concussion management, bridging the gap between clinical recommendations and real-world academic implementation. This concludes Module 8 and the final module of this continuing education course on concussion management in adolescents and adults. Thank you for your participation. We will now review the exam questions to solidify your understanding. Listen carefully as we walk through each question, identify the correct answer, and explain the reasoning behind it. This review covers 10 questions from the course, Concussion Management in Adolescents and Adults, Evidence-Based Update. Question 1. Which of the following is a component of the SCOAT6 that distinguishes it from the SCAT6? The correct answer is C. Orthostatic blood pressure and heart rate testing for autonomic dysfunction. Rationale? The SCAT6, or Sport Concussion Assessment Tool, 6th edition, is a well-established sideline evaluation instrument that includes the Post-Concussion Symptom Scale, the standardized assessment of concussion for cognitive screening, and the modified balance error scoring system. The SCOAT6, or Sport Concussion Office Assessment Tool, 6th edition, is designed for more comprehensive clinical follow-up in the office setting. One of its distinguishing features is the inclusion of orthostatic vital sign testing, specifically blood pressure and heart rate assessment in supine and standing positions to screen for autonomic dysfunction. Autonomic dysregulation is a recognized consequence of concussion that can contribute to symptoms such as exercise intolerance, dizziness, and fatigue. By incorporating this component, the SCOAT6 extends the evaluation beyond what the sideline SCAT6 provides, offering clinicians a more thorough picture of the patient's physiological recovery status. Question 2. According to current evidence-based guidelines, what is the recommended approach to physical activity during the first 48 hours after concussion? The correct answer is B. Relative rest with permission for light, subsymptom threshold activities such as walking. Rationale: earlier concussion management guidelines advocated for strict cognitive and physical rest, sometimes referred to as cocooning, where patients were placed in darkened rooms and told to avoid all stimulation until symptoms fully resolved. However, a growing body of evidence has shown that prolonged strict rest can actually be counterproductive, leading to secondary symptoms like deconditioning, anxiety, depression, and social isolation that may prolong recovery. Current consensus guidelines from the most recent International Consensus Conference on Concussion in Sport recommend a period of relative rest lasting up to 48 hours. During this time, patients are encouraged to engage in light physical activity that remains below the threshold at which symptoms worsen, such as gentle walking. This approach supports physiological recovery while avoiding the harmful effects of complete inactivity. Question 3. Which targeted intervention has the strongest evidence for patients with persistent dizziness, neck pain, and headaches beyond 10 days after concussion? The correct answer is D. Combined cervical and vestibular physical therapy, also known as cervicovestibular rehabilitation. Rationale. When concussion symptoms such as dizziness, neck pain, and headaches persist beyond 10 days, a targeted rehabilitative approach is warranted. A landmark randomized controlled trial demonstrated that patients who received combined cervical spine treatment and vestibular rehabilitation were approximately 3.91 times more likely to receive medical clearance for return to sport within 8 weeks compared to those who received a control intervention. The cervical spine and the vestibular system are closely interconnected, and concussive injuries frequently affect both. Cervical dysfunction can contribute to headaches and dizziness through cervicogenic mechanisms, while vestibular impairment can cause balance problems and visual disturbances. By addressing both systems simultaneously through cervicovestibular rehabilitation, clinicians can target the overlapping pathophysiology driving these persistent symptoms, making this the most evidence-supported intervention for this clinical presentation. Question 4. Which pharmacological agent has the strongest evidence for improving cognitive dysfunction, specifically attention and processing speed, following mild traumatic brain injury? The correct answer is A. Methylphenidate. Rationale. Cognitive difficulties, particularly in the areas of attention, processing speed, and executive function, are common following mild traumatic brain injury. Among the pharmacological agents studied for this indication, methylphenidate has the most robust evidence base. A meta-analysis examining its effects on cognitive functioning after mild traumatic brain injury found a small but statistically significant positive effect, with an effect size of 0.34. The improvements were observed across multiple cognitive domains, including executive memory, baseline processing speed, and inhibitory control. Methylphenidate works by increasing dopamine and norepinephrine availability in the prefrontal cortex, which are neurotransmitter systems critical for attentional processes and executive functioning. The other options, including topiramate, propranolol, and donepezil, do not have comparable evidence supporting their use for cognitive dysfunction, specifically related to mild traumatic brain injury. Question 5. In the graduated 6-stage return to sport protocol, what defines an acceptable symptom exacerbation during exercise that still allows progression to the next stage? The correct answer is D. No more than a 2-point increase on a 0 to 10 scale that resolves within 1 hour. Rationale. The graduated return to sport protocol is a stepwise framework that allows athletes to progressively increase physical demands while monitoring for symptom responses. A key clinical question is how much symptom exacerbation is acceptable during exercise without requiring a return to the previous stage. The protocol defines a mild and brief symptom exacerbation as an increase of no more than 2 points on a 0 to 10 symptom severity scale compared with the patient's pre-exercise baseline, provided that this increase resolves within 1 hour after stopping the activity. If a patient experiences an exacerbation that exceeds this threshold, either greater than 2 points or lasting longer than 1 hour, the protocol calls for the athlete to return to the previous stage and reattempt progression after an appropriate rest period. This criterion provides clinicians with a practical, quantitative guideline for making return-to-sport decisions that balance the benefits of progressive activity with the need to protect the recovering brain. Question 6. When planning a return-to-work protocol for a worker in a sedentary, cognitively demanding role, which of the following accommodations is most appropriate? The correct answer is B. Limited screen time with frequent breaks, reduced multitasking, and a quiet workspace. Rationale. Return to work after concussion requires thoughtful consideration of the specific cognitive and physical demands of the individual's occupation. For workers in sedentary, cognitively demanding roles, the primary challenge is managing cognitive load during recovery. Appropriate workplace accommodations include limiting screen time with frequent rest breaks to reduce visual and cognitive fatigue, reducing multitasking and complex problem-solving demands that tax attentional resources, offering flexible work hours to allow the worker to perform during periods of optimal cognitive function, and modifying the work environment by reducing noise and visual distractions. These accommodations facilitate a gradual return to full cognitive function. Both immediate full-duty return and prolonged complete removal from the workplace are unsupported by current evidence. The former risks symptom exacerbation, while the latter may contribute to deconditioning, anxiety, and delayed recovery, much like the rationale against prolonged strict rest in the acute phase. Question 7. Which objective assessment tool is considered the most established measure for determining a patient's physiological readiness and guiding individualized aerobic exercise prescription after concussion? The correct answer is C. The Buffalo Concussion Treadmill Test, or BCTT. Rationale: the Buffalo Concussion Treadmill Test is a graded exercise test specifically developed for the concussion population. During the test, the patient walks or runs on a treadmill with incrementally increasing intensity while the clinician monitors for symptom exacerbation. The test identifies the heart rate at which the patient experiences a more than mild increase in symptoms, known as the symptom exacerbation threshold. This heart rate is then used to prescribe an individualized subsymptom threshold aerobic exercise program, typically set at approximately 80% of the threshold heart rate. The BCTT serves two important clinical functions. First, it provides an objective measure of physiological recovery by determining whether exercise-induced symptom provocation is still present. Second, it enables clinicians to tailor aerobic exercise prescriptions to each patient's current tolerance level. The other tools listed, including ANM, the Pittsburgh Sleep Quality Index, and the Quality of Life After Brain Injury Scale, measure different constructs and are not designed to assess physiological readiness for aerobic activity. Question 8. According to the Graduated Return to Sport Protocol, athletes should not advance beyond Stage 2, which is light aerobic exercise, until which condition is met? The correct answer is B. They have returned to pre-injury symptom levels and are fully participating in school. Rationale: the Graduated Return to Sport Protocol recognizes that cognitive recovery and academic reintegration should take priority over sport-specific physical demands. Stage 2 of the protocol involves light aerobic exercise, such as walking or stationary cycling, at an intensity that does not provoke symptoms. Before an athlete advances to Stage 3, which introduces sport-specific exercise, they must have returned to their pre-injury symptom baseline and be fully participating in school or equivalent cognitive activities without accommodations. This sequencing reflects the clinical principle that the brain should be able to handle the cognitive demands of daily life before being subjected to the additional physiological and cognitive stress of sport-specific training. Advancing through sport-specific stages while still struggling academically could compromise both cognitive recovery and academic performance. Question 9. What is the primary reason self-managed computerized cognitive training is not recommended for patients with persistent post-concussion cognitive symptoms? The correct answer is B. It has been associated with worse cognitive and neurobehavioral outcomes compared to clinician-directed rehabilitation. Rationale: while computerized cognitive training programs are widely available and may seem like a convenient option for patients with persistent cognitive difficulties after concussion, the evidence does not support their use in a self-managed format. Research has demonstrated that self-directed computerized cognitive training does not produce meaningful or sustained improvements in cognitive function. More importantly, it has been associated with worse cognitive and neurobehavioral outcomes when compared to clinician-directed cognitive rehabilitation. Clinician-directed rehabilitation involves individualized assessment of cognitive deficits, targeted intervention strategies, real-time feedback, and systematic progression, all of which are absent in self-managed programs. The supervised, adaptive nature of clinician-directed approaches allows therapists to adjust strategies based on the patient's evolving needs, monitor for compensatory behaviors that may mask true progress, and address the emotional and behavioral factors that often accompany persistent post-concussion cognitive symptoms. Question 10. Which intervention has been classified as having the strongest evidence among non-pharmacological approaches for preventing persistent post-concussion symptoms? The correct answer is A. Early provision of psychoeducation, information, and advice within the first 4 weeks after injury. Rationale: a systematic review and meta-analysis published in JAM-A Network Open examined a range of non-pharmacological interventions aimed at preventing the development of persistent post-concussion symptoms. Among all interventions studied, the early provision of psychoeducation, information, and advice emerged as having the strongest level of evidence. This intervention involves educating patients about the expected course of recovery, normalizing common symptoms, providing reassurance about prognosis, and offering practical guidance on activity management and gradual return to daily activities. The recommendation is that this intervention begin within the first 4 weeks following injury. The effectiveness of early psychoeducation likely stems from its ability to reduce anxiety and catastrophizing about symptoms, set appropriate expectations for recovery, and empower patients with strategies for self-management. When patients understand that most concussions resolve within a predictable time frame and that their symptoms are a normal part of the healing process, they are less likely to develop the fear avoidance behaviors and psychological distress that can contribute to symptom persistence. This concludes our exam review. Remember, the key themes from this course include the shift from strict rest to early guided physical activity, the importance of individualized multimodal rehabilitation for persistent symptoms, and the value of evidence-based return to sport and return to work protocols. Good luck on your exam.